how it affects people. And
welcome, ladies and gentlemen, to our virtual meeting on interventional cardiology held by the Vietnam Society of Interventional Cardiology in association with the Thống Nhất Hospital, Ho Chi Minh City, and particularly to be joined by faculty from America. This is the session 3 with the topic Optimal PCI of the left-man lesion. The left-man lesion is the very most important lesion because it supplies whole left heart, and as we know, just 40% of the myocardium be affected, the patient fall into cardiogenic shock. And the left-man lesion is the largest bifurcation with the cerebral not small, such as the circumflex. And the left-man lesion is a large vessel with a diameter and mid-mark between left-man and circumflex or LAD, and sometimes table shape. And it has a recoil elastic bound. It's very strong because the ostium of LAD, ostium of circumflex, ostium of left-man is often very calcified. So left-man PCI is really challenging for interventionists. And so today we hope this our meeting is very interesting and very beneficial. We can hear very excellent presentation, very discussion, opinion from experts from the Vietnam and America. I am Dr. Hồ Thường Dũng, the president of the Vietnam Society of Interventional Cardiology. And to be co-chair, my co-chair, Dr. Thạch Nguyễn from America. Dr. Thạch Nguyễn is director of the Cardiovascular Research Laboratory, Methodist Hospital, Maryville, and the academic dean Tân Trào University School of the Medicine, Long An Province, Vietnam. And today we are very happy, very honorable to have the Dr. Tim Murray Henry, President of SCI, Society of Cardiovascular Angiography and Intervention of America. Welcome, Tim Henry. And
thank you, Dr. Ho.
Yeah, and Dr. Tim Henry, a professor of Liner Family Distinguished Chair in the Clinical Research and Medical Director of the Con and Edith Liner Center of Research at the Church Hospital, Cincinnati, Ohio. And by now, we would like to introduce the faculty of US team. And then the next, Dr. Quan Ly, Associate Professor Quan Ly, Division of Cardiology, Associate Program Director, Cardiovascular Disease Fellowship, Cardiovascular Service Line, Director, Banner University Medical Group, Tucson, Director, Cardiac Catheterization Laboratory, Cardiology Clinic, Banner University Medical Center, South Tucson, Arizona. And the last but not least, Dr. Mark Birnia, Interventional Cardiology, Hospital of Lavlas Medical Center, Albuquerque. By now, I introduce the Vietnamese faculty. First, myself, I have already talked. And the second, Professor Nguyễn Ngọc Quang, he Vice Dean of Vietnam Heart Institute, Hanoi Capital, and Ambassador of the SCI Vietnam. The next, Associate Professor Đỗ Văn Huân, ex-Director of Heart Institute, Ho Chi Minh City, Vietnam. The next, Associate Professor Nguyễn Văn Tông, Director of Interventional Cardiology Department, Thống Nhất Hospital, Ho Chi Minh City. Vice Director, Geriatric Department, University of Medicine and Pharmacy, Ho Chi Minh City, Vietnam. The next, Dr. Ngô Minh Hùng, Director of Interventional Cardiology Department, Chợ Rẫy Hospital, Ho Chi Minh City, Vietnam. And the last but not least, Dr. Nguyễn Đỗ Anh, Director of Interventional Cardiology Department, Nhân dân Gia đình Hospital, Ho Chi Minh City, Vietnam. Welcome all of you. And by now, the time of you, Dr. Thạch Nguyễn.
Dr. Hồ Thượng Dũng, thank you. It's a time for Dr. Tim Henry to give a welcome remark from the US.
So first of all, I'm delighted to be here. Good morning in Vietnam, and it's actually Saturday night in the United States. And I just was, we were talking, and actually 2 years ago, almost 2 years ago, before the COVID, I actually had 10 wonderful days in Vietnam. It was my first thing, and I was in Ho Chi Minh City. It was fabulous. It was one of my favorite times. So I wish I was there with you tonight. And second of all, I want to say from a standpoint of being president of Society of Coronary Angiography and Interventional for SCI, that our goal is to represent interventional cardiologists around the world and patients who need interventional cardiology. And so our goal, and in particular, we have a very close relationship in Vietnam, and we want to do everything that we can to support that in terms of guidelines, best practices, and educational programs. So I'm absolutely delighted to be here. And Tak and I are actually neighbors in the United States. And because I'm now in Ohio and he's in Indiana. So I'm delighted to be here. And so welcome on behalf of SCI.
Thank you very much. And I would like to, it's my turn to introduce the first presentation. But before I introduce Dr. Tim Henry, I just remind you, Tim, in front of you, they are the best, the brightest interventional cardiologists of Vietnam. Now I introduce Dr. Tim Henry. Dr. Tim Henry. Yes, Tim.
Go ahead, Tak.
Dr. Tim Henry was a great researcher in the care of STEMI in Minneapolis. Then he moved to become chief cardiology at Cedars-Sinai Hospital in Los Angeles. His office was on Beverly Boulevard, West Hollywood. I'm sure he has so many patients who are movie stars because Barbara Streisand was a big donor for Cedars-Sinai. Then after a glamorous career in California, he moved to a world-class cardiac center, the Christ Hospital in Cincinnati. Besides being a great clinician, skillful intervention cardiologist, Tim is also a great thinker, researcher, and innovator with provocative ideas. It is my privilege to introduce Tim, President of SCI, to give the first talk today. It is
Delighted.
about PCI of left main in STEMI clinical trials. Thank you.
All right, can you hear me?
Tim Henry.
I think actually I hear it was a, can you hear me? And can you see my slide?
Very clear.
Okay, perfect. So what I'm going to do is talk today about STEMI, and Dr. Quan Lee is going to talk about left main, but I'm going to specifically talk about left main as a culprit in ST elevation MI. And so what we know is, oh, now are you hearing my tape or you're hearing this?
We hear you live.
Yeah, we hear you clearly, and it's yeah, loud and clear.
It's live. It's not the tape.
Are you hearing the tape or are you hearing me?
We hear
We are
you.
hearing you.
Okay. I'm going to let it go.
Hello, Tim. Please go ahead and give the live
Can you
lecture.
hear me? Can you hear me or not?
We can hear clearly.
We hear
All right,
you
good.
very well. Hello, Tim. Please give the live talk.
Tim, yeah, Tim,
Yeah.
I think we don't hear the tape. We don't hear the pre-recorded at
All right, perfect. So then I'm going to do, because that's weird because there's a tape going. So I'm going to do this. So, all right, that's perfect. Thanks, Quan. So what I want to do is talk, first of all, about left main culprits. And so number one, there's not a lot of information about STEMI and left mains. And it's an uncommon, but a potentially devastating clinical effect. And if you look at clinical trials, it varies from 0.8 to 5.4%. There's limited data about the clinical characteristics and outcome. There's a meta-analysis from JACC Interventional with 12 studies and 977% patients in 2013, but it was unprotected left main, and they had 26% cardiogenic shock. But 9 of them were single center, and only 3 included patients who had cardiac arrest. And then what I'm going to do is actually show you data from the Midwest STEMI Consortium, which I think is very unique. And then, so here is the problem when you have an ST elevation. The problem is you have plaque rupture. And then the solution is to do PCI, or what I call 1-hour artery cleaners. And so, and the question is a surgeon relevant to this topic? And it's a really important issue, and that I think that what we're talking about with STEMI and left main, it's not really a surgical situation. This is a situation where you need to do PCI and you need to fix the culprit vessel. I think it's rare that you actually have the time and that the patients can do better with surgery. So I'm going to start with a case. So this is a 50-year-old woman that presented with acute onset of tearing in my chest at 1:30 a.m. And she was 120 miles away from Minneapolis Heart. And she had VFib twice at the non-PCI center. And the EKG showed ST elevation. She was transferred by helicopter, and she arrived in cardiogenic shock with O2 sats of 70% and her blood pressure in the 80s. And this is her initial EKG. And the initial EKG, this is actually ventricular tachycardia. So we shocked it. And this is her second EKG, which shows extensive ST depression and EKG changes. When you see an EKG like this, and in fact, I was on call last night and had a similar situation where there was extensive ST depression and ST elevation in AVR. And in fact, am concerned that this is actually a left main STEMI. So she went to the hospital, and this is actually the EKG. Can you see that? So so she had a extensive dissection in the left main that it went down both the circumflex and LAD and had a completely normal right coronary artery, okay? And so here's my question. This says, oh Lord, here comes circumstances beyond our control. And I think when you see this patient, the answer to that is not, because this should be, for a good interventional cardiologist, that this should be something that you can handle. You don't call the surgeon, you don't do conservative care, and it's not circumstances beyond our control. So this was a spontaneous dissection of the left main. And obviously she was in cardiogenic shock and she had an out of hospital cardiac arrest. And the point is to be calm, to get the wire in the true lumen, and then to stent the left main. And 8 minutes after arriving in the cath lab, even though we shocked her, we had to put a stent in her left main. And this is actually the final picture. And so you can see this is actually about 20 minutes later. We did have to put 6 stents in the left main, all the way down the LAD, but you can see we have excellent flow in the circumflex, excellent flow in the LAD, as well as in the diagonal. She did terrific. This is actually a picture. 6 years later, her ejection fraction was 60%. She basically had almost no hypokinesis. She was completely asymptomatic, and she published a book about her experience. And that's what can happen. And remember, this is a lady who is 2 hours away from a PCI center. And I think the really important point is to have a standardized protocol set up to deal with ST elevation and to handle it, even the sickest of the sick patients. So we're going to talk a little bit about what's available in left main in terms of STEMI. So there's not that much data. This is data actually from 2009, and this was all acute coronary syndromes. 4% had a left main culprit, but this included both STEMI and not STEMI. But I think the most important point about this paper was this. Over the course of time, in terms of acute myocardial infarction, the use of PCI has increased and the use of bypass surgery has decreased, because we know that in the setting of an acute myocardial infarction, that bypass surgery has higher risk. So when you looked at this, when you looked at the patients who got PCI, 60% were STEMI. When you looked at conservative, 40% were STEMI, and CABG, 40% were STEMI. So more often, when you have a ST elevation MI, you actually need to do PCI. So this is the largest paper that's available. This is actually the acute myocardial infarction in Switzerland registry. And this is 7,000 patients. 5% had primary PCI of the left main. So it was 348 patients. And some interesting things, if you look, 10% of the patients had a cardiac arrest prior to arrival, 12% had cardiogenic shock, and 16% required a vasopressor. Now, when you look at mortality compared to left main versus non-left main, the in-hospital mortality was 10% versus 3.8%. The in-hospital death, if you had cardiogenic shock, was 54.8% versus 35%. So if you have cardiogenic shock, it's higher risk, but if you have cardiogenic shock in a left main, it's a specifically higher risk. And of course, there was higher MACE, which is not surprising. Now, this is another data. This shows the opposite. This is actually from NCDR, and this looks at ST elevation MI and non-ST elevation MI. And it shows the number of PCIs is actually relatively uncommon, 0.2%. So what is it? Is it 0.2% or is it 5%? And in particular, what they say, this is uncertain because these patients have a traumatic presentation, including sudden death. So we're going to talk about that. When you looked at the NCDR data, you found of the left main culprits, 66% had cardiogenic shock. So that was significantly higher than when you presented with non-STEMI and significantly higher than the overall group. Now, also, if you had a left main, if you look on the left, the in-lab mortality was 20% and the in-hospital mortality was 60%. And what I would tell you is that's higher than it should be. And if you look, if you had a non-STEMI, if you had a STEMI, but you were not a PCI, you can see there was obviously a much lower incidence of PCI. So here's the point about left main, STEMI with left main. It's a relatively unusual situation. It's a very high risk situation that presents with cardiogenic shock. But what I'm going to now do is show you data that comes from the Midwest STEMI Consortium. So this is a group of hospitals, 4 hospitals, and it also includes Cedars-Sinai. that includes all of the STEMIs that we did from 2005 to 2019. And what we did was we looked at the patients who had a left main culprit and compared left main culprit to non-left main culprit. And this is actually the data that I think is really important. Patients are a little bit older. Patients, 16% of the patients had a cardiac arrest compared to 7.9. So twice as likely that you come in with an out-of-hospital cardiac arrest. Cardiogenic shock was 32% compared to 6%. So much more likely that you have cardiogenic shock. Obviously, the majority were anterior infarction, and the ejection fraction was 37% compared to 47%, so much lower. So absolutely, these are older, they're lower ejection fraction, more cardiac arrest, and more cardiogenic shock. But it's more complicated than that. So when we actually looked at the left main culprits, we found 4 distinct different clinical scenarios. So number 1, there's the patient who comes in and has an unprotected left main that's occluded. Obviously, that's the highest risk situation. And actually, many of these patients actually die outside the hospital. So when you looked at that, that was only 24% of the culprits. 60% of the patients had a culprit in the left main that was actually open, and they had TIMI 2 or TIMI grade 3 flow. So it's a much better, they're much more likely to survive. Many of them do have cardiogenic shock, but the artery's open and you actually have time to fix it. A third situation is you have a protected left main. So you had previous bypass surgery. And obviously that's not nearly as high a risk. And then the fourth and very unique situation that I showed you earlier is the patient who had the spontaneous coronary artery dissection. And that was 5% of the left mains. So it's not rare. And I'm not sure in Vietnam, actually. That's a good question we'll ask about spontaneous coronary dissection, of how often that happens in Vietnam, in Vietnamese patients. So these are the 4 things. So number 1 on the left is a left occluded left main, and that's obviously the highest risk. On the right, you see the subtotal occlusion, which was the most common of the patients who actually made it to the cath lab. Then you have the protected left main, and then you have the left main dissection, which I showed you already. So again, if you look at the left main culprit, they're more likely to actually have TIMI 2 or 3 flow. And that, why would that be? Because of course, if you have an occluded left main, many of those patients don't actually make it to the hospital, but they are less likely to have TIMI grade 3 flow after it. They were a little less likely to get primary PCI because some of those patients still in this thing went to surgery, but we looked actually at the data, and the patients who actually had PCI did better than the patients who went to buy surgery. There was definitely a higher mortality, and it was 30% mortality in a left main STEMI compared to other STEMIs, which are only 4.5%. And it was markedly higher, of course, if you had a cardiac arrest, if you had cardiogenic shock, or if you had an unprotected left main. So in conclusion, patients with STEMI due to left main are small, but a high-risk patient population with 4 very distinct clinical presentations. Emergency PCI is not only feasible, but it's life-saving. And I would encourage you, I think when you have a patient with STEMI who comes in with left main, that I believe that the best approach is actually to do PCI. It can be done safely and can be done effectively. There is higher mortality, in particular if patients who have cardiogenic shock or unprotected left mains. But importantly, the final thing I'll say is the number of people that actually have a left main culprit that die prior to getting to the hospital is, of course, unknown. So I'm going to stop with that, and I'm going to end right there, and I'll be happy to answer any questions.
Tim, this is Mark Bionniers. Out of the 20 or so patients with complete occlusion of the left main, what was the mortality on that? Because I can count on one hand in my entire career how many people I've saved with that condition.
Yeah, actually, Mark, it was better than you'd think, but you have to remember they actually made it to the cath lab, right?
Yeah.
And so the mortality in the group of patients that had an occluded left main was about 50%. Whereas if you come in with if you come in with Timmy 2 flow and you have a left main culprit, actually those patients do very well. The spontaneous coronary dissection patients, even though they're very sick, about 30% of them have cardiogenic shock. The number of patients that died was very small. So it's a really important point. I actually think that, with spontaneous coronary dissection, we say that you should treat them conservatively. That is not when you have ST elevation and when you have hemodynamic significance. And I think they can be dealt with very, very well. And our results, our overall results, with SCAD and left main, even though 30% of cardiogenic shock, the mortality was under 2%. So I think almost all those patients do well if you are aggressive and treat them with PCI. And then of course, the final group is the patients who have a previous CABG and have an protected left main, and they do very well. So I think it's interesting though, because no other previous data has ever separated it out. You know, you just say left main culprit, but these four things are very different.
Yeah. Tim, thank you for sharing that fascinating data set. You know, there's so little published about it, so it's phenomenal to see, you know, something as to what's been happening here with specifically with this cohort. And I totally agree with you that when left main patients present, if we are able to, we should certainly stent instead of delaying to surgery, and we really need to, I think, to push that as an agenda forward. You know, no society has been willing to take on that specific statement just about yet. In the patients that went for surgery, what was the average time delay in your cohort from presentation to surgery? And did anyone try to use PCI as a bridge to surgery? You know, a lot of times in many of our protocols, our patients get Brilinta, and prasugrel or clopidogrel up front in the ER before they get to the cath lab. And that often leads our surgeons to become extremely reluctant to take them early on. Was there any insight into that data from your registry?
Yeah, I'll tell you there's two things. Number one, it's mixed group because there is a group of people that have a left main culprit, but they arrive and they're very clinically stable. And you look at the data, you look at their angiogram and they're stable enough that they actually can wait and have surgery semi-electively. They do fine. And that will happen. So if you look at 100 patients, that might happen in 5 out of 100. But then there was a group of patients who went to surgery emergently, extremely poor outcomes, extremely poor outcomes. And so I think that if someone is in cardiogenic shock, if they're hemodynamically unstable, I think in STEMI, the treatment of choice is PCI.
No, Tim, I would like to invite the best and the brightest of Vietnam, Dr. Ngô Minh Hùng. You are from Chợ Rẫy, the flagship of the hospital in the South Vietnam, and Dr. Nguyễn Ngọc Quang from Vietnam Heart Institute, and then Dr. Hồ Thường Dũng from Thống Nhất, and Dr. Nguyễn Đỗ Anh from Nhân dân Gia Định. Ngô Minh Hùng, please, it's your turn.
Yeah, thank you very much, Professor Thạch Nguyen. Yeah, good evening, colleagues from the US. And actually, I very interested to join the first presentation, and I had a question for Professor Tim Henry about the PCI for the left man. Actually, in Ho Chi Minh City or in Vietnam, the patient usually came to the cath lab quite late after the onset of chest pain, and with totally occlusion of the left man. So usually we revascularize very quickly and restore the Timmy 3 flow, but the myocardium is still maybe gone a lot. So what is your recommendation for this kind of patient? Usually the after 12 hours of chest pain, and now we restore the ischemic pre-flow, even that, but the patient had the severe heart failure. So what is your recommendation for this kind of group of patients?
It's a great question. And I think that the answer is you can do it. So two things I think happen in this group of people. Number one, they don't do well with pressors. So if you, and I think this is a bigger issue about cardiogenic shock, which we actually talked about last week. With cardiogenic shock, pressors work if you have heart failure or you're post bypass. But in the setting of acute myocardial infarction, if you have people on pressors, even if you open up the left main, the arteries are intensely vasoconstricted.
Yeah.
And so even though you open the left main, you don't have actually good perfusion. So I strongly believe that the group of people that have a occluded left main, and you open the left main, they're going to need to have mechanical circulatory support. And I think if you have, so 3 levels of that, one is balloon pump, and probably many of these people are too sick for that. The second is Impella, and then the third is ECMO. And actually, the patients who had ECMO and got a PCI were the ones who did the best.
Yeah. Thank you very much. And I have another question for you. Usually the patient came with the occlusion of acute occlusion of left main, so they had a lot of thrombus at the very close to the coronary sinus. So what do you want to suck it out, or you just wiring the lesion and then do the ballooning and everything? So what do you refer to suck the thrombus out first with the catheter, or you just do the ballooning at the usual? Thank you.
So that's a really good question, because I think that's a very highly variable. And I think, so I'm going to actually take that as a bigger question in terms of thrombectomy for STEMI overall, because I'm not sure that, in left main itself, that we have enough people to actually make a distinction. But here's what I'd say. I'd say that we know that the routine use of thrombectomy is not effective and not necessary. But I do think that there are selected patients who have significant thrombus that thrombectomy can be effective. And in particular, at TCT last week, the CHEETAH trial, it was not randomized, but it showed the outcome with the penumbrum system, which is it's thrombectomy that's a little more aggressive. And I'm not sure if you have penumbrum in Vietnam or not, but I do think in the United States, that's my current choice of if I have a patient who has STEMI, who has very severe thrombus, that I would use the penumbra system.
Thank you.
Thank you. Can I talk to Dr. Nguyễn Ngọc Quang, please?
Hi, Professor Thạch Nguyễn and Dr. Hatiam Henry. Thank you for the great talk on left main PCI. Usually, we're facing the same situation in Hanoi and in Vietnam, I think. So basically, when the patient came in with the left main occlusion, and if the patient is not have a hypotension, so we think that we just go ahead without any mechanical support because if patient die, they already die. So if they can go to the cath lab, we just open it. However, I think about 60% of patients with left main occlusion have a cardiogenic shock, and it is a really terrible situation because we don't know what we need to do. Pressure is not so good as Tim mentioned. We only have IABP. ECMO, actually, when you put for ECMO for the QMI, and sometimes you see because you cannot unlock the left ventricular, so that's why the patient got a very severe heart failure after that. So it is a very, like a frustrating situation. We only can put the IABP and then we go ahead as quick as possible, even without the thrombectomy, because sometimes we don't know what was going on for the side branch. And when we wiring through the left main occlusion, we cannot see the distally, so we don't know that the wire go into the big distal vessel or not. So we just open it, try to restore the flow as quick as we can. Usually we just putting stent from the left main to the LAD and just ignore the sub. So this is the real situation. So
yeah, and I think you're 100% right. I mean, clearly, for those of us that do STEMI and for a long, this is a left main occlusion is clearly the most difficult case that we see and most difficult to deal with. But I also think, and I'm not, and it's a little biased because these were people who made it to the hospital, but I would say that the outcome, half the patients did survive and actually did quite well. And now, can I ask my colleagues from Vietnam, spontaneous coronary artery dissection, how common is it in Vietnam?
I think into my side maybe less than 2%.
Mm-hmm.
Yeah, really low. Usually we or another situation, because patient in Vietnam usually came late, so sometimes we cannot differentiate the spontaneous dissection with the real AMI type 1. So maybe we can miss, but for the case we can identify clearly spontaneous coronary dissection is less than 1 or 2%.
Mm-hmm.
Hello, Dr. Ho Tung Yung.
Yeah. The first, the spontaneous coronary dissection in Vietnam, I think very, very low. I just met 1K. And I like to come back the topic. The last week, I asked Dr. Timoney, multivessel disease, complete revascularization is right, and everything is okay. But after the culprit substitution, ESC guideline give the class 3 contraindication if the patient in the STEMI cardiogenic shock, we open only culprit lesion. I think I agree that if unnecessary, we don't open more. But in some case, the hemodynamic not improve, and the remaining non-culprit lesion is very important. Or maybe the non-culprit lesion is very soft, and very easy to open. Why we cannot open? So I ask you about one more again.
Yeah, no, that's a great question. It's a really important question. And here's what I would say. The standard is, if you don't have cardiogenic shock, should be that patients benefit from complete revascularization. And we know that from the COMPLETE trial. Now, the question is the timing of complete revascularization. And actually the COMPLETE trial showed, so you can do that at the same setting. You can do it in the hospital stay, or you can even discharge a patient and do it within the first month, or even first 6 weeks is what they did in COMPLETE. Now, I think that this is one of those things that requires judgment. And if you have a large risk territory and you have another small area, then I think you should wait. If you have a complicated PCI, if you have renal insufficiency, then I think it's better to do the culprit vessel and wait.
Right.
And I think what the opposite is true. If you look at the culprit shock data, that the patients who came in the hospital with a STEMI and cardiogenic shock, and they did actually worse with multivessel PCI at the same time. So I think that the standard is right now is if you have cardiogenic shock, and so a left main with cardiogenic shock, what I would say is fix a culprit and do mechanical support that you need, and then wait to do the complete revascularization at a different time. And I think the left main is a very unique I mean, this is a talk. It doesn't happen all the time, but I think it's one of the most critically ill group of patients that we deal with. So I think it's important to discuss it and important to think about it.
Thank you very much. Dr. Nguyễn Đỗ Anh. You have to unmute yourself.
Yeah, I unmute already. I think that the cardiogenic shock with the alignment occlusion is the dilemma for all of us. Annually, our hospital received about 10 to 20 cases like this, but actually because of they admit to our hospital, it's a very severe clinical status there. So some case, I think it's that nearly 30% died in the AD department before arriving to the cath lab. The second thing is concerned about how the MCS. As we know that the Ebola is not available in Vietnam. It's just in Ho Chi Minh City also just only ECMO, and I think the IIPP is popular. It's popular in every, I think every hospital also have, but actually because now it's not use routine. But like our hospital, we have no choice. So if we receive some cases, we also do the EIPP first. Second, we also open the upgrade with the projection and the standing from Labman to LAP. But actually, annually, the mortality in our hospital for the Labman occlusion STEMI is the mortality in hospital mortality is 70%. Just only 30% can survive. Even though they survive, they will readmit to our hospital on the next several months because of the second of the heart failure. About the spontaneous coronary dissection, I think it's relative. In Vietnam, I'm not sure because we don't have the random. We have the data. But actually, in our hospital, I think it's less than 1%. Some case, well, we can not on the CAG, but now some case is looked as it's not clearly. And some also have a good flow, so we will detect why we use IVUS. We also detect some cases like this, but actually, even we detect optimal mecon treatments for some cases indication. Just PCI just only when the hemodynamic, the unstable, or the slow. That's it.
Thank you, Dr. Nguyễn Đỗ Anh. Dr. Nguyễn Văn Tân, you have any? Can you share your experience with us?
Yes, thank you, Professor Thạch Nguyễn, and good morning, everybody. So I agree with your comment, but in my hospital and my opinion, I think unprotected Labman PCI is challenging and very, very dilemma. So most of case with unprotected Labman usually dies before admit the hospital. So when the patient admit the emergency department, so if we suppress the Labman occlusion, so we stretch the patient to immediately to the cath lab. So when we have a coronary angiography by the unprotected Labman, so I think I agree with Dr. Nguyễn Ngọc Hoàng. First, you open the Labman first, very important. So at that time, if your cath lab, we have the mechanical cardiac support, we can set up at the same time. So if we wait for the mechanical support, cardiac support first, very important, very dangerous. Sometimes the patient views that appears VT or VF and the patient die. So after use CBR, very not good and not good for the patient during the PCI. And I think we should have a teamwork, very important. Many doctor can help you at the same time. You can PCI and another doctor can support for you mechanical cardiac support resuscitation for the patient later. Thank you.
Hello, Tim. Now you have 3 jobs. Number 1, you have to answer the question about SCAD in pregnant women.
Yes.
What should we do? Number 2,
Yeah, I'm looking.
You wrap
Good,
up and you give as the big brother. Now you tell us what you think about what the work of the Vietnamese interventional cardiologist for STEMI. And number 3, you introduce Dr. Quan Le.
So, all right. So first of all, I think that with spontaneous coronary artery, it's definitely more common with pregnancy. And I think and that's what I didn't know. Actually, I wasn't sure how common it is in Vietnam. It actually in Europe and the United States, it's more common than that. And I think it's underappreciated. And it's actually the patient is the young woman with no risk factors is a really thing. And I think we published a paper in the Journal of American College of Cardiology last year that showed when you come in with ST and the standard discussion about SCAD is that it's conservative therapy, and that's fine if you are a non-STEMI or if it's distal disease. But when you come in with STEMI, 30% of those patients have cardiogenic shock and you need to fix it. And our data that we published in JACC showed that you can fix it very effectively. The mortality of a patient with SCAD, even though they had a higher incidence of cardiogenic shock than atherosclerosis, they had a better long-term outcome. So don't be scared about it, about fixing it, if they are hemodynamically significant. If it's a distal lesion or it's a side branch, then fine, treat it conservatively because they will heal. But the patient who is hemodynamically unstable, you need to fix it. All right, so then let's go on because what I would like to do is actually introduce the next talk, who is Dr. Quan Le, who is actually from Malaysia. I didn't know that, Quan. But as Quan said to me earlier today, he is a friend of Vietnam. And so delighted to have you. And more importantly, he's now the acting chief of cardiology at the University of Arizona, so in Tucson. So welcome, Quan. And actually, he's going to talk about left main PCI, and so an extension of what we just talked about. So welcome, Quan. Thank you.
Thank you, Tim, for that very kind introduction. And before I start, I just want to also say thank you once again to Professor Ho and Professor Tak Nguyen and the Vietnam Society of Interventional Cardiology for this opportunity to be back. I seem to be back every week, and it's really good to spend time with good friends. All right, so the title of my talk, and let me get it up here. I've been asked to talk about an overview of left main PCI, which I'm supposed to cover in 15 minutes. As you can imagine, this is a massive topic and it's very complex, and each of our slides, we could probably go down a rabbit hole and spend another 20 minutes talking about each of these things, but I will try my best to hit on all the major highlights of left main PCI, and these are my disclosures. Left main has for the longest time been considered the highest pinnacle, the holy grail of PCI, as Dr. Henry alluded to earlier. It's long been considered, along with CTOs, the riskiest, most challenging subset of PCI. And over the last 15 to 20 years, we've seen significant guidelines evolution as the interventional community has made the remarkable effort of showing us how we can do left main PCI. In 2005, the ACC/AHA SKY guidelines basically said that unprotected left main was a class 3 indication, PCI not recommended in patients eligible for CABG. And then 13 years later, in the 2018 ESC/EACTS guideline, we have a class 1 indication for unprotected left main in low syntax score, class 2A for moderate syntax score, and class 3 for high syntax score. The big part is that we may be taking a step backwards, as in 2019, after some scandal with the Excel study, the EACTS announced that they were withdrawing their support for left main PCI within the guidelines, and we have yet to see the final outcome of that debate. So we made a lot of progress forwards, and we may be stepping backwards. What are the special anatomic features of left main disease that makes it more challenging? First of all, there is a size mismatch between the branches and the left main. There are many permutations and combinations of occlusions with Medina configurations. It can also involve the ostium, and osteo PCI, as we all know, can be challenging in itself. The angle between the LAD and circumflex is usually large, so you have to make very tight turns as you try and pass stents down. There tends to be a large territory subtended by the branches, and the side branch loss, therefore, it becomes very consequential. You sometimes get trifurcations. There's frequently not just left main disease, but also LAD, circumflex, RCA disease, and you tend to see CTOs when you see left main disease. And once again, it's commonly associated with poor ventricular function, so it makes those patients more difficult to work on. How do these anatomic issues translate into technical problems? You now need to start to understand your knowledge of stent selection and expansion profile knowledge becomes hyper important, and that is not always well covered, I think. Your knowledge of bifurcation techniques becomes critical, and we have clearly shown that experience counts in treating left main disease. When you can get osteo PCI issues, you can over protrude the stent into the aorta. You get longitudinal compression of stents as your guide goes back and forth. When you have calcified lesions, this can make the whole thing even more challenging. You need to know your intracoronary physiology and imaging. And then obviously you have the hemodynamic instability risk. And then you need to be very familiar with all your MCS support devices. Downstream, the consequences of stent thrombosis can be catastrophic, and therefore the tolerance for suboptimal stent results is much lower. And the importance, therefore, of intracoronary imaging is thus magnified significantly. Who should we perform left main PCI in? This has been an age-old question. And how do we choose which patient should get CABG or PCI? As we talked about earlier, what about the acuity of the presentation and the presence of cardiogenic shock? Definitely, I think that swings us in the direction of PCI. What are we choosing really when we choose CABG versus PCI? Are we looking at the ultimate long-term outcomes? What are our goals of care in that short phase where we want to do PCI, etc.? And in Asia, as we all know, there's significant patient cultural preferences. So you may have all the data in the world, but your patient just wants PCI. And you should do it, right? And then what are the local expertise and resources to support either method? If you're not good at PCI, left main, you probably shouldn't do it. And then ultimately, this is probably the most important statement for the global pandemic, COVID-19, is the issue of healthcare resources. When you do CABG, your patients stay in the hospital for a long time. If you look after them with PCI, they can go home. I've been sending some of my left main PCI, and despite recommendations who are very stable, and we got very nice results, same day, radial, left main, go home. And that has really cut down on our use of beds that would had to go to COVID patients. And there is a national shortage as well, the United States, of nursing staff right now. So what's the evidence that support unprotected left main CABG versus PCI? We have 6 trials in total. Le Mans, Syntax, left main, pre-combat, Excel, and Noble are the most significant studies. You can see that, I'm not sure how many of these are actually relevant to current generation because they involve use of bare metal stents as well as first generation DES. And really only Xience and Biomatrix involve the use of contemporary DES. And the data for those is, 5 years, etc. In meta-analysis of these data, in general, the results we got were equivalent in depth, equivalent in MI, with the caveat that there was a big a fight about the definition of MI and the impact on ultimate outcome with XL that led to a lot of the, the disagreement with the surgeons, etc. And then stroke. PCI is clearly inferior for ischemia-driven revascularization over time compared to CABG. So that is CABG's primary claim to fame, but the rest of the stuff, it actually does, PCI does quite well. The other important question to ask is, what are your outcomes according to the syntax score? And as we saw from the ESC guidelines, within the XL data set, when they broke it down to syntax score less than 22, you see that, yes, in general, we have equivalence. When you start to push out, to mid-range syntax score 23 to 32, the curves start to diverge in the opposite direction, and very high syntax score, very clearly PCI is inferior to CABG. The one caveat that we would call out is that within the XL study, there was massive discrepancy within how the site cardiologists categorized the patient in their syntax score versus the core laboratory. There was almost 70% disagreement between what the cardiologist said their syntax score was and what the core lab is. The syntax score, as we all know, is hard to calculate, and therefore, given its centrality in exactly how you choose who to send to PCI and CABG, this is something we all should know exactly how to do. And physicians frequently underestimate what the syntax score truly is. We engage in confirmation bias. We want to stent the patient, therefore we undercalculate syntax scores, or is it just that we simply don't know? Oh, sorry here. Trying to find my, okay, and then this is some of the media articles surrounding the XL, very public arguments, and it's not over yet. So we may see a regression of the ESC guidelines. It's possible. As you know that when you make decisions for CABG versus PCI, it is much, much more complicated than simply even just your syntax score. This is a very complicated slide, but I thought the Korean Society of Cardiology actually did a very good job with this. And you can see that there's so much that goes into it with regards to deciding one way versus the other. There's the entire patient to consider, what is your STS risk score? What is your Euro score, etc. The things that help favor CABG beyond simple syntax, diabetes, low EF, contraindications, that obviously prior history of diffuse instance restenosis. Given all these things, you must look at the patient in totality. You cannot use just little blips of data here and there, and you must involve the heart team. And that's been a significant revolution in how we make decisions. So heart team decision for ultimate which direction does the patient go. This is a slide summarizing a little bit more about this interesting question as to how to decide unprotected left main significance. We use angiographic, right? Greater than 50% is quote unquote significant. When we start using physiology and IVUS, though, that number is not great. And therefore, you should always supplement that with pre-CAF non-invasive results if that's possible. We all know about the IVUS, 6 millimeters squared, that has been validated, as well as in Asian patients, that number is smaller. It's 4.5 millimeters squared. And I'm not sure what you use in Vietnam. I suspect it should be 4.5 millimeters squared. That's from the Korean data. There's no real OCT data. And you have to also remember that OCT tends to underestimate size compared to IVUS by 10%. There is quite a lot of FFR data with about 8 trials. Last trial was about 2009, looking at FFR deferral 0.80. FFR, as we all know, in left main is subject to a lot of crosstalk between lesions. And this is graphic on the right is a summary by Dr. BK Koo that shows you all the ways that your FFR may not be correct if you don't understand how to use it in the evaluation. The good thing about IFR, recently, as of 2020, there's now been IFR data supporting deferral of left main PCI or revascularization from the defined left main registry, and they actually had 300 patients and showed pretty much the same thing. So IFR now has supporting data to also help you decide who to revascularize. Now, this is a big one. PCI techniques for distal left main. What is the best technique, right? These are all your options. You can do the single stent provisional. You can do pot only, pot side pot, pot kiss pot, right? If you do provisional, if the side branch is still compromised after ballooning, you can convert that to a tap, a reverse crush, or a culotte technique. Or if you choose an upfront two-stent strategy, you can use the T-stent, the tap, the DK crush, the culotte, or the reverse culotte. And that's an issue of semantics, but many of us don't actually correctly distinguish between what a reverse culotte and a culotte is. So that's a nice technical little point. There was a network meta-analysis of bifurcation techniques published in JACC Interventions last year. And you can see that overall, in this large meta-analysis, DK crush was clearly superior to the other two stent techniques, crush, culotte, and T-tap. But as always, the answers are not always as clean as you would like. To understand the results of that meta-analysis, almost all of their data came from DK Crush 3 and DK Crush 5. So we have to be familiar with at least these two studies. The DK Crush technique, as we all know, is Professor Xiaowen Chen's described method. DK Crush 3 was published in 2015, and this was DK Crush versus culotte. It was multi-center international, unprotected, true left main disease. They excluded heavy calcification, trifurcation, and big left mains. They randomized 1-to-1 DK Crush versus culotte, and they used Zions and Firebird 2 stents. IVUS use was high, about 70% of patients. Final kissing balloon, as you would expect, was very, very high, and angiographic success was very high. Overall, with time, they showed at a 3-year follow-up that DK Crush was superior to culotte in outcomes. This was then followed by DK Crush 5, asking this very important question: is DK Crush 5 better than a provisional stenting methodology? Once again, similar trial design, true left main disease. They excluded shock, calcification requiring atherectomy instead restenosis. They used, once again, Zions, Firebird 2, and Resolute DES. Here, the IVUS use fell, surprisingly, to about 40% from 70% for DK Crush 3. Very high use of pot, and not that high use of final kissing within the provisional stent group, which we'll see is not that big a deal. 47%, this is very high, in the provisional group eventually underwent tap bailout. So that is, I think, significant for the results. What did they see? They saw that target lesion failure in provisional stenting was quite a bit higher compared to DK Crush over 3 years with a progressively increasing thing. And most of it actually occurred at the ostium of the left circumflex. And what they then did was that they then looked at the data to try and understand what really helped favor. And they saw that the more complex your left main disease, the better DK Crush performed. So if you had multiple bifurcations, you had thrombus, your reference vessel diameter was small in your main vessel, your lesion length was greater than 25 millimeters, here 10 millimeters, you had severe calcification, your bifurcation angles were not good, therefore categorizing as a complex lesion. The provisional technique had almost a 20% 1-year TLF rate versus 7% for DK Crush, versus 8% if it's for simple lesions to 3.9% for DK Crush. The EBC main study, which was something that everybody was trying to look forward to help finally answer the question, because despite all the DK Crush data, the European Bifurcation Club, which we can argue is the most significant bifurcation group on the planet, has not been a fan of the DK Crush. So we all hoped that this would give us the answer, and the data was published this year, but it did not provide us any answers. It was basically a European multi-center study. They randomized patients to set wet provisional versus systematic two-stent. The mean syntax score was 23. They did include patients with heavy calcification to which they rotablated the arteries. And don't forget that DK crash excluded those patients. But ultimately, I think the study failed because what they chose was a two-cent technique. They left it up to the operators. And most people chose culotte technique at 53%, and then TAP at 33%. And then DK crash was only 5% of the patient. The technique that's supposed to be the best technique, is now not being used. And then in the provisional group, 11% of them ultimately got culotte, 11% got TAP, and ultimately 78% had a single stent. But once again, the syntax score is lower. It was a good study. POT was high, not 100% or 90%. I think you could, some people argue that POT is compulsory. And then IVUS and OCT use was also very low. And what did they see at 1 year? The results suggested that there was no difference between with a trend towards favoring the stepwise provisional. One of the primary criticisms of EBC, whenever you listen to them, is that DK crash is hard to learn. Now we actually have simulational devices that help you walk through the DK crash technique. And I think this is something that we probably should look at in the future to help everybody get past that argument that it's hard to learn, therefore you shouldn't do it. And because these cases are rare, you can't learn it, and therefore you go around in a circle. And I don't think that's fair. When it comes to calcified plaque modification for the left main, as we all know, there are 5 options: cutting, scoring, balloon, rotational atherectomy, orbital, laser, and intracorneal lithotripsy. When you try and modify the plaque in the left main, the consequences are all magnified. The consequences of dissection, perforation, and no reflow magnified. This increases the possible need for support, even in elective cases. And then it's also very difficult to wire protect the side branches with rotational or orbital atherectomy. It is not impossible, but very difficult, and most people actually do not do it. We sequentially work on vessels with rotablator for the most part. This is a Italian group kind of trying to suggest how you do this. You double guide wire main branch, side branch. If it's uncrossable, you take out the side branch, and then you do the atherectomy, and then you move forward. If it's crossable, if you have access to lithotripsy or cutting balloon, etc., they suggest you try that first before converting over to atherectomy. Here is a little cartoon showing how exactly Iacone et al. Described how they protected with 2 wires a side branch in rotablation. They had a mother in guide type of thing. They put a guidezilla forward. They ran the rotablator on the guidezilla into the side branch and left a secondary wire up front. It sounds great, but I don't think many of us would actually do this. What about intracorneal imaging to optimize left main PCI? There's actually been a lot of data on this. There have been randomized trials and meta-analysis of randomized trials that have all favored the use of IVUS. I just picked one of these studies, and that's a novel sub-study from the novel randomized trial. They looked at all of the patients who got IVUS to guide left main PCI, and they looked at 5-year outcomes. And what did they see? They saw that clearly 5-year MACE, with post-PCI IVUS versus no, there was a trend, right, towards significance. But when it came to target lesion revascularization, it was a clear trend with reduction in target lesion revascularization at 5 years if you used IVUS. One of the difficult questions is what, and in that study, they didn't actually say what were they using IVUS for. And that's, I think, unlike IVUS, XPL, etc., there's really been no define what exactly are you doing with that information, and there needs to be future randomized trials asking that exact question. You want to use it, what are you doing exactly with that information? So how do you use intracorneal imaging? You use it first to ask the question, is revascularization necessary? Is there significant calcium? Is there need for modification? It guides procedure technique. How much does the disease extend into the circumflex? Are the osteo of the circ and the LED involved, for example? Obviously, step dimension optimization is important. You want to maximize your expansion post-PCI. in the world of OCT, there is this interesting idea of choosing the point of side branch wire crossing, depending on the technique that you're using, such as DK crush, etc. You want to avoid malapposition, and then you want to check for geographical miss and edge dissection. You know, these are how you probably best practices for intracorneal imaging. What about the use of mechanical circulatory support? You know, MCS and left main PCI is used as A, elective high-risk PCS support, or B, ACS, cardiogenic shock bailout. There's no study out there that conclusively shows in randomized trials to be beneficial. It's probably due to the large heterogeneity of patients. But in all of this who use MCS, there is no question, I think, that it is definitely beneficial in certain individual patients. We, I think, have just failed to clearly define that subgroup. The cost, as we have said, is beyond the IBP is prohibitive. And then there is, you know, the three things you can use, and as well as the specific combinations you can use them in. What about the question of prolonged DAP? Now that you've performed a PCI in your left main patients, and I think we covered this at the Vietnam National Heart Meeting quite nicely last week in our DAP session, but major registry data supports prolonged DAP after left main PCI. And this data that I chose to show here from one of the several groups is from Korea, the Korean PCI registry, and they show that you know, if you use longer DAP, given that you don't have any bleeding issues at 1 year, you know, long-term outcome, there's really a reduction in death, MI, stent thrombosis, etc. And it's especially true when you use a two-stent technique. So we will wrap up here, just reviewing together the current consensus statements. So EBC 15 consensus, PCI for unprotected left main, they reconfirmed that data supports PCI for selected patient. The results are influenced by the left main pattern and atherosclerotic burden, i.e. the syntax score. It should be performed by experienced and appropriately equipped team. DES should be selected carefully based on pot sizing. The provisional strategy is preferred, once again, by EBC, not DK crush. And intracorneal imaging and functional tools, these are all soft statements, may improve decision-making, and you should have a low threshold for intracorneal imaging. The new statement was once again recognizing the efficacy and limitations of PCI and CABG, and to reiterate heart team decision-making. The last guidelines, 2018 ESC guidelines, 1B says in patients with left main and multivessel disease, syntax score should be calculated. And once again, I want to emphasize that you need to know exactly how to do it so you do it correctly. And then you have the 1A for low syntax score for PCI, 2AA for intermediate, and then 3B for high syntax score. It's a 2AB recommendation that IVUS should be considered to optimize treatment of unprotected left main lesions. It's a 2B statement. They actually, contrary to EBC, the ESC guidelines actually say something about DK crush. They say that it may be preferred over provisional T-stenting as a 2B recommendation. And then some other minor but important statements. 2B, prasugrel or ticagrelor may be considered in left main elective stenting. That's one step higher than ACS. Left main should be performed by operators with greater or equal to 25 left main PCIs per year, 2AC. And then non-emergency PCI for left main should only be performed by experienced operators at centers with the appropriate circulatory support and ICU care. And then this is an interesting one. After left main PCI, late, i.e. 3 to 12 months surveillance angiography may be considered irrespective of symptoms, and that's a 2B-C. So I'd like to conclude. I hope I haven't gone over time too much. There's a lot to cover. Number one, PCI has gained increasing acceptance for left main treatment versus CABG. CABG is superior for more complex anatomy. During the COVID-19 pandemic, the PCI advantage is lower healthcare utilization. CABG versus PCI requires heart team decision-making. PCI at left main is technically complex and should only be performed by experienced operators and centers. Likely, I'm gonna go out here and just say this, contrary to what EBC tells us. DK crush is a superior two-stent technique for complex anatomy, and provisional is probably better for less complex anatomy. And I believe, despite the soft recommendation from ESC, that intracorneal imaging should be compulsory. You know, we need to get past this. We need to, there was an abstract published at TCT from Sunil Rao from the NCDR data, showing that within the NCDR data set, that in the last 2020, use of IVUS OCT is 3 to 2%. And that is just embarrassing. I don't even know what to say to that. Thank you. Hope to see you all in person soon. These are photos. I was up in the Albuquerque International Balloon Fiesta. This is where Dr. Bianaris is from his beautiful city, one of the largest balloon festivals in the world. Thank you very much. And I look forward to questions.
That was a great presentation, very comprehensive, and I think challenging to all of us as we look at tackling these. The presentation that I have on tips and tricks is going to back up pretty much statement by statement what you said. I do have a couple of questions for you, though. You started out talking about one of the challenges to left main PCI is the size mismatch.
Yeah.
And when you encounter significant size mismatch between and you're doing a 2-stent technique, most times you're having to bridge from the large left main into the LAD, say. How often do you try to flare the stent into the left main, guiding that with IVUS, and putting in a longer stent because of that?
Yeah, I always do that. I always use POT. I think the more we've used intracorneal imaging and the more we've studied, the results after we deploy stents, I've definitely moved in that direction. One of the specific problems with doing that is that you have to know your size maximum expansion profiles, and there are certain stents that don't do well, right? The Orsiro does not do well. The Ultimaster does not do well. Xience probably has one of the best mismatch size, and you have to reference your tables. They change, and one of the issues I found as well is that many Caucasian patients, their left mains are 6 millimeters, 6.5 millimeters. And we don't have balloons. The only balloon on our shelf is the Emerge NC at 6 millimeters. Every other balloon, the maximum size is 5.5 millimeters or 5 millimeters, which really, challenges you in trying to achieve that. But nowadays, I always leave enough length, with also the understanding that if I push the stent too hard, say I have the wrong size, that you are going to get longitudinal shortening. The stent cannot go beyond, if I put a 6 millimeter and say a 2.5 millimeter Resolute, that distance needs to be longer than balloon you put in.
Hi Quang. I have a short question about the stent thrombosis of the left main. So how about the rate of the stent thrombosis after you do the PCI for the left main in elective case and as well as in acute setting?
Yeah, that's a great question. I think, in acute setting, given that you tend to have a lot of thrombus around, certainly the rate of downstream stent thrombosis is higher than elective setting. I think you can mitigate some of that by good application of intracorneal imaging. And unfortunately, I don't think it should be OCT, because in the setting of thrombotic disease of the left main, you cannot see past thrombus, right? And if you really want a good apposition, good matching of sizes, I think it has to be IVUS to really reduce that, because there's no other way to know. And we've all seen that where we deploy the stent, as the patients get better and the anti-thrombotics work, we bring them back, and the next thing you know, you're looking at really significant malapposition that you had no idea was there when you deployed your stents.
So a couple of comments. First of all, on Dr. Lee, thank you. It was I thought it was excellent. Covered a lot of ground in a short time. I think a couple key things. Number one, I do believe the decision about whether, I do think left main in 2021 is a reasonable thing to do if you do careful patient selection. And I do think that it's very important to involve the patient and the surgeon in that decision, and so that they have a clear view of what the positives and negatives are. That being said, I think if you're going to do PCI, then I do think this is one of the situations where imaging is essential. And I agree with you. Everyone doesn't, but I agree with you that IVUS is preferred, personally. And I think the technique, the problem with this about technique is that left mains are very heterogeneous. It's not like there's one size fits all. And so I think this is one of those ones where I think experienced interventional cardiologist judgment is a really important issue. And but I think that you need to plan effectively. And I think another really important point is your issue about mechanical circulatory support. It certainly has not been proven that you need it. And I think if you do it effectively, I think you can do left mains effectively without it. And I think it depends on what the left ventricular function is and et cetera like that. But, and I think that's another really important issue because I think if you do DK crush, it's more complex and there's more chance for ischemia than there is if you do other techniques. So if you have someone who has an ejection fraction of 25% and they're not a candidate for surgery, and for some reason that they're not amenable to mechanical circulatory support, you need to use your judgment of how you do that patient.
Yep.
And, you know, I did one last week, a patient who had terrible lung disease. And we got an outstanding result in left main. The patient went home 4 hours later, same day thing. And it's done great. So I think it's judgment and it's not one size fits all.
Yeah, no, for sure. I think that's why especially in the left main, you have to take all those things into consideration. And speed sometimes is probably your best saver when it comes to the question of whether you need MCS. If you can go fast and accurately, it's it helps you obviate the need for MCS. And the other thing that's really changed left main therapy for me in the calcified lesion subset is lithotripsy, because of the lack of downstream, no reflow, etc. And the fact that you just go up quickly, you get it done. There's none of this like walking out, switching, etc. You just go deliver the thing, and then you're flying.
Now, is Shockwave available in Vietnam right now? Not yet.
No.
So I will tell you that for all those you out there, it'll dramatically change your life. And I completely agree with that. It completely changes your approach to this, because I think either if you do rotoblade or CSI, I personally haven't done laser as much. So my experience is with rotoblader and CSI. And I would tell you that Shockwave completely changes the game in terms of doing left main in terms of calcified lesions. And let's be honest, a lot of the patients that the surgeons say they don't want to do are severely calcified, bad left main, right? So they're complicated for the surgeons. They're also probably complicated for us.
On a different note, and I'd love to hear from our colleagues in Vietnam also about this. In the US guidelines, we have competence requirements for PCI. You see the ESC guidelines recommend for left main PCI to have an experience level of greater than 25 per year, which I think is probably appropriate. I love hearing people like Dr. Henry say, oh, last week I did this and today I did this. And it's always these super complex cases. And, I live in an underserved area where our volumes are just through the roof. But our competence requirements for PCI are 50 per year to be considered competent. And I don't think that's responsible, honestly. And I'm kind of talking out of my personal opinion rather than clearly out of the guidelines. And I'd love to hear opinions on this, specifically for left main.
You are president of the Vietnam's Interventional Society.
Yeah. very difficult to answer this question because in Vietnam by now we don't have a very strict about stipulation how many K the interventionist do left main BCI. They have the right to do the left main BCI. But I think in the near future we must have the very strict rule for the interventionist, because in the 1 year, 2 years ago, we interventional cardiology grow very quickly. So by now, in particularly in chronic coronary syndrome, I think acute coronary syndrome is okay. Acute coronary syndrome and acute MI, the doctor bring the patient to the cath lab and to try to the open revascularization immediately is the right. But in chronic coronary syndrome, the indication for stenting or so for many stenting, how many stenting right or wrong. I think in Vietnam we must change. I think in this session we have Professor Nguyễn Ngọc Quang, Ambassador of SCAI Vietnam. Can you give some opinion about us?
I think we totally agree about the competence for the intervention, because however you should maintain the standard of care, especially for the acute coronary syndrome. However, in Vietnam, because we have a lot of patients, and actually every hospital have an overload of the patients, so basically the number of cases of PCI is every intervention is already passed. So I think is not a big deal for the number of cases. But however, the standardized protocol is very important, because we need to maintain the way to to ensure the quality of care for the patient in acute setting. For example, how to use a thrombectomy is in the effective and safety way is very important, because the patient in Vietnam usually come late and have a very big burden of thrombus. So we need to, the guideline should be applied locally, and we need to make sure that every interventionist do the right thing in the right time by the right protocol. So I think it's important for the Society of Intervention, as well as the Vietnam National Heart Association, working closely with the SCAI to make sure that we have the best standard of care for the patient in acute setting.
Thank you, Professor Nguyễn Ngọc Quang. And by the way, I introduce Associate Professor Đỗ Văn Huân. He the expert of interventional cardiology in Vietnam have just come in. Dr. Đỗ Văn Huân, can you give some comment about that?
Yeah, good morning, and thank you, all of you. I think that the standard for the intervention is very important. Yeah, because when we do the intervention, we should care about our patient, and the number of patients when the interventionist do the left main BCI is very important, because left main is the most important vessel in of the heart, and therefore I think that in the future we should build the standard number of patients for the interventionists when they perform the left main BCI. But in Vietnam, we have a lot of standard which in which the interventionists do the left main BCI, and the experience of those doctors is very good, and I think that the result for the left main BCI for patient are were good too. But in the future, the left main BCI standard we should build. Thank you.
Okay, thank you so much, Professor Đỗ Văn Huân. So I think the next time the standardization of the practice in the interventional cardiology in Vietnam is very important. It is our duty, and so we need the support from the SCAI and support from Vietnam Heart Association. It's our duty. We must pay attention to that.
We would be delighted to help with that.
Yeah, and I had the question that when you perform the PCI, left main PCI, should you use the old way ticagrelor or prasugrel plus aspirin for those patients, or in the first 1 or 2 months, or you could use the clopidogrel plus aspirin?
Hello,
Oh, I'm
Tim,
sorry.
this is a question for you.
Yeah.
Quan Lee.
Quan, what do you think?
Yeah, I think, you know, as the ESC guidelines state, you know, it's a 2B recommendation. I think obviously pushing the degree of P2Y12 inhibition up 1 notch is probably wise. But once again, that has to be balanced off against the patient who is not a high bleeding risk patient. And unfortunately, most left main patients, as we all know, the high risk patients are also, high ischemic risk patients are also high bleeding risk patients. So that has to be taken into account. So I think some of the newer DAP de-escalation strategies that we have seen are very interesting, and perhaps they could be applied. So for example, starting with ticagrelor for a month afterwards and then dropping to clopidogrel, unguided or perhaps guided, versus prasugrel 10 milligrams to 5 milligrams. You know, we have those 2 trials from Korea in the last year or so. You know, that might be a way to go. You know, it's hard to know. Obviously, there's never going to be enough patients to do a true randomized trial with that. But you know, it will have to come probably from registries.
But I do think, from my personal, I think your point when you did it, I think we should err on left main in particular are more complex, and we should err on dual antiplatelet therapy unless there's a significant bleeding problem. I think it's still too early to, you know, it's one thing if it's a mid RCA, but I think in the complex left main PCI, to stop dual antiplatelet therapy is premature.
Dr. Kwali, can I ask you a question about the strategy for left main intervention? Actually, at the moment, we have the ongoing trial about the revert tap versus decay crush. So the trial is started in 2018, and then maybe end at the 2024. So what do you think about the revert tap for left main intervention? That's quite challenging procedure. Yeah.
Yeah, you know, I mean, I think we need to complete the trial, obviously. I think the more data we should not, we need to enrich the data environment as much as possible. I think the part that a lot of these trials failed to do, and I think was a lost opportunity, was to mandate IVUS use. You know, I can't believe that we have had all these left main trials in which IVUS imaging was not mandated to optimize. I suspect ultimately that mandating imaging use, whatever technique you use, as long as you have a good imaging result, and then we have to define what we mean by using it. Just sticking an IVUS probe down is not using it, right? Within the United States, very interestingly, NCDR PCI codes your procedure as quote unquote appropriate just by use of IVUS or OCT. You don't have to even justify what you found with IVUS or OCT. It automatically changes it to appropriate, which is crazy. So I think mandated with a clear instruction algorithm as to what you do with the outcomes, and the understanding as well that many of the IVUS optimization studies you could not achieve. Like some of the studies, right, 50% of patients, despite the algorithm, no matter what you did, you couldn't get to that number, you know. And we also have to understand the reasons and effects of that. One of the very interesting points about lithotripsy in the future is that a lot of the regret that we see, whether it's eccentricity regret or expansion regret, we could potentially overcome in the future with the use of lithotripsy within the stent. The company says that you damage the polymer when you use lithotripsy acutely up front, but we actually ran it. We did a little sub-study with electron microscope here at U of A, and we stuck a Zion stent and we lithotripsied it in vitro, and there was nothing. We couldn't find anything wrong with the polymer. So lots of questions, but clearly the study needs to finish.
Yes, thank you.
Okay, I think our session meeting still have many presentations, so by now we must move to the next presentation. And it seems the next presentation is my presentation. Can you see my slide clearly?
Yeah, I can.
Yeah, I like to talk about the hybrid PCI, a very challenging case of left-main coronary intervention, and I have some case with the large remaining vessel. The character of left-main PCI, I talked briefly. Left-main trunk is very special anatomy of coronary artery because supplying blood for whole left heart. Large bifurcation with no small side branch, require elastic strong power, a large vessel diameter mismatch table, and characteristics of the last remain vessel PCI very high because it's supplied in blood for almost whole left heart because it's often settled in the right coronary. So a very high PCI must have a mechanical circulatory support. And when we determine or consider complex coronary bifurcation, the complex bifurcation PCI depends not only anatomy of bifurcation itself, but also the whole of the coronary artery tree. And according to our classification, phenotypic classification of complex bifurcation, true bifurcation at unimportant localization with greater than one of following. Important localization in the underlying, it means a distal left main or position supplying for a large amount of myocardium. And criteria heavy calcified bifurcation, to a sequential attendant bifurcation, 3 clinical stenosis lesion nearby. Because if we do intervention to complete bifurcation with critical stenosis lesion nearby, it's very easy to induce a critical ischemic crisis, and it meant maybe we cannot follow our strategy. Triple vessel disease, small diffuse disease, thrombus containing lesion, and repeat revascularization of a stenting bifurcation, and the large remaining vessel is the factor we talk about us today, trifurcation, quadrifurcation. And if bifurcation in combination with greater two criteria is very complex bifurcation. And according to a 2020 SKY consensus, cheaper complex PCI, we have a 3-factor anatomy such as the calcified bifurcation left main CTO, comorbidity, as diabetes, ketogenic soft vascular heart disease, and particularly the third group, the SKY chain from hemodynamics, the compromise to the equipment. So equipment needed to perform a complex bifurcation in Vietnam. We have intravascular imaging, IVUS, OCT. We have intracoronary physiology, FFR, IFR. Guide catheter extension, we have a Gidazella, special coronary Y. We have a special balloon, we have a cover stand, atherectomy. Atherectomy, we have only rotator. An empolic protection device, we have filter Y, mechanical circulatory support, we have mainly a balloon pump. The ECMO after the COVID-19 pandemic, many hospital and medical lab have an ECMO, but utilization of ECMO in the treatment cardiogenic shock, I don't believe that we can do. So I have one case for the demonstration first. 57-year-old with past medical history bypass 5 years ago, and 1 year ago he often were admitted for the diagnosis of acute heart failure and non-STEMI chest pain. And this is Korean angiogram. You can see small diffuse left main involved through the LD and circumflex. And calcified lesion of the distal left main and proximal segment of LD and circumflex. And in this case, the right coronary have a critical stenosis of proximal of the coronary artery disease and in the PDA, osteum and proximal segment of PDA. This case not true large remaining vessel, but equivalent if we go direct to the left coronary artery. So the first we must do intervention to the right, and I consider if we can open the right coronary artery, we have native circulatory support, and the need for mechanical circulatory support for when we do PCI to the left maybe not unnecessary. So the first we do stenting, we open the proximal of the right coronary artery, and we try to open in ostium and proximal segment of PDI with the aim to give a more collateral blood flow to the left. And after we open the lesion in the right coronary artery, we go to the left, more comfortable, easy. But now we go to the left, pre-dilatation, and roll up later. Distal left main look very calcified. Proximal segment of the LDD. Pre-dilatation before stenting. And we must use key the Zilla to print the stent to pass long lesion and tortuous lesion. Zilla can see here, and we print the first stent to the mid LDD. And the second stent to the proximal LD. And last stenting for the left main. I think before, after we open the lesion, the lesion of the right coronary artery disease, the intervention to the left coronary artery disease not very high risk. So in this case, mechanical circulatory support only balloon pump standby in advance. In advance, we then insert the balloon pump in the body. Filthy. So the last result is good. It's okay. Is that right? The left. So I go to the second case. This case, maybe this case is true large remaining vessel. The patient 55 years and the past medical history bypass surgery 5 years ago. And the patient admitted to the local hospital with the diagnosis very high risk, non-STEMI, and do coronary angiogram, and he referred to the ALCA lab. You can see total occlusion in the right with the very calcified. In the lab, we can see the pipe bypass trap to the LD lost, but the bypass trap to the circumflex still, because we can see the watershed phenomenon in the circumflex. And in combination with the very difficult lesion in the lab, we have a small aneurysm of calcified severe stenosis of proximal LD. Dr. Kwali, do you remember the last case at the last meeting? With one more case.
Yes.
And this aneurysm smaller. But when I have one aneurysm in the severe lesion or severe calcified lesion, I am not confident enough to do pre-dilatation or rotablator because I'm not sure rupture or not rupture. If the aneurysm rupture in this very high PCI look like this case or last case is very dangerous. We print one cover stand to this the lesion very calcified and tortured. I think may be very difficult, and look in this situation, I think the disaster may happen. So the first we try to do again native circulatory support. It means if I can open right coronary artery, the problem become more easier. And we do with the Sutkin catheter, dry Sutkin catheter fail. We can to the arm blast catheter, and with the Gaia 2, it can cross. So if we can open the right, it means we breaking down equivalent large remaining vessel. It become the normal vessel, not large remaining vessel. It's very high and very dangerous. So after we do the right, we go to the lab easier. It's not truly left-man disease. It have the distal left-man with proximal LD. Just left-man disease. I'm sorry. And by now we try to the coiling the small aneurysm. Not very difficult. After we coiling the small aneurysm of the proximal segment, the problem become easier. We can pre-dilatation. We can do a standing. Not very difficult. So the last result. The true large remain vessel. If we can open the CTO, the problem become comfortable. The next case, the true large remaining vessel. And what you see in the lab, a calcified lesion and diffuse long lesion. In this case, we cannot open the right. So we must go direct to the lab. With mechanical circulatory support, only balloon pump standby in advance. It means we have just an insert small vascular asset, the seed about five francs in advance. If we need to yield the balloon pump, we change to the larger seed and to insert the balloon pump. But during procedure, the balloon pump stand by in advance. And during procedure, sometimes slow flow, but after we use the balloon, dilatation is okay. So the balloon pump not used. And we do a proton later. And after we do proton later, we stand in. So this guy, the true large remaining vessel. Dilatation up. The last result. Before and after PCI. Before and after PCI. And this case, the last case of the last meeting, Dr. Kwanli, do you remember? There's a CO of the right coronary artery and very calcified in the lab. And we do not PCI to the right, we go to the left. And in this case, we have the large aneurysm in the mid segment. You can see. And with the experience, the first case, we try to open the distal ligament with the pole ostium of the LAD and circumflex. But we avoid the segment with the aneurysm. Rotablator, distal ligament and proximal segment of LAD, but avoid the segment with aneurysm. Then we do stenting the distal ligament and prop segment of LAD and prop segment of circumflex, the decay cross techniques. And we have a stent regress of the prop segment of LAD, and we use the NC balloon 3.5, 3.0, 12, 3.5, 12 with the very high atmosphere 22, 24. The last is open. This is the final result, the first PCI. It means the segment severe stenosis and calcified with the aneurysm still there. We can see the aneurysm still have it, and in this area we cannot open because I'm not confident enough to dilatation in this area. I'm not confident enough to do the rotor in this segment. The final after the first PCI, the patient feel well. He think the heart failure, the symptom improve. 6 days ago, we go again to do the last segment with the aneurysm. 6 days later, we coil in again. After we coil in the aneurysm, I have enough the confidence to dilatation segment, calcified segment of the mid LAD and stenting. I think the last result is okay. And before I finish my presentation, I like to talk something about the mechanical circulatory support for for the high risk PCI, and particularly in Vietnam. I think some Vietnamese interventionists look like Dr. Ngô Minh Hùng agree with me about the way the Vietnamese interventionists use the mechanical circulatory support in high risk PCI. We have one trial impeller compare versus with balloon pump in a patient with a QMI complicated in a cardiogenic shock. And the result, you can see in hospital clinical outcome with endpoint death and a major bleeding. You can see balloon pump better. Major bleeding, balloon pump still better. And in hospital outcome stratified by timing of device placement, I think all endpoint, or I think the balloon pump still good. The first and the second, I like to talk about the feasibility and safety of high-risk PCI without mechanical circulatory support. In Vietnam, we often perform high-risk PCI, but only with the balloon pump standby in advance, but not insert balloon pump in the body of the patient. And I think the most of case we can do successfully without complication. And so the last week, Dr. Ngô Minh Hùng sent me some slides. And I think according to registry of this registry, we can see the rescue mechanical circulatory support, it requires only 1.8% of the patient with the high-risk PCI. So I think I don't know about in the near future. In the Vietnam, we have an impeller or something on. We can use the impeller, put it inside the body of the patient. But by now, with the balloon pump, most of case we have a balloon pump by a standby in advance with a small seat in the femoral artery. So go to the conclusion of that home message. A coronary artery disease of elderly very severe. The field taught to us have a heavy calcified, particularly type C bifurcation left-main 3VD CTO. PCI in the elderly require advanced technique and assistant instrument is certain sure. Revascularization in the elderly should be modified in the case very complex disease. Many stage PCI look like my last case. We must do the first time, the second time, the third time. It may be reasonable, acceptable, or try, particularly at very high procedure risk. Left-main PCI in association with large remaining vessel PCI is very true, challenging or difficult. We must use modification atherectomy in combination with a stent technique. Opening occlude RCI in the situation large remaining vessel should be done before we do the PCI to the lab. And we must need the mechanical circulatory support. Okay, thank you so much for your attention, my presentation. And I look for your comment or your advice. Thank you so much.
Thank you very much, Professor Dũng, for your presentation. So I would like to ask Professor Wang and Professor Huang about give some comment about the presentation and give some tip and trick for the BCI for the large remaining vessel for in clinical practice. And after that, I will ask the US colleague to join to comment on this presentation. Thank you. Professor Wang and Professor Huang, please.
So basically, first of all, I would like to thank the great talk and great case Professor Dũng already present. So I think that try to identify the most important vessel is very important to make the appropriate strategy for the PCI. I think that we, as long as Professor Dũng present for the first two cases, I think that we need to open the other vessel first to make to increase the chance and the safety for the patient. And the second point is usually we need something to support like IABP. So if we got that, we can go to tackle with a very difficult case like Professor Dũng did. Thank you.
Yeah, Professor Huang, please.
Yeah, thank you, Professor Dũng, for very challenging cases. I think that you did successful for your cases. First of all, I want to those cases we have the indication for CBG, and good you do the left main BCI with the very calcified lesion and tortuosity and the aneurysm for those patients first, and the second are with the very small aneurysm. Could you leave the small aneurysm, and when you, we put stent, the aneurysm, the stent cover a part of the aneurysm, and the aneurysm will not rupture. I think that those case of Professor Dũng did very well. Thank you.
I had the comment about your presentation that did you do the IVERS or OCT for the aneurysm before you coiling the lesion in order to stay away from the rupture? Thank you.
Okay, thank you your question, and thank you your comment in my case. The first in my case, it's very tortuous, very calcified, and in the time I perform this GK, I have OCT, and do you know the OCT catheter is very delicate and very not stiff enough to go tortuous. It often gets stuck. And when I have the IVERS machine in this year, the IVERS very good for we use in the very special difficult and tortuous calcified look like that. But in some case with very high risk hemodynamic compromise, look like my case, when we use the catheter of the IVERS into the vessel, something wrong. But you know, some guy I cannot give a microcat for the chain proton wire. So if we use the catheter of the IVERT inside the coronary artery, it will get stuck and it will induce critical ischemic crisis, very dangerous. So I must go directly. I only use the intravascular imaging after we do the successful PCI. But in this situation, we only see the stent scallop good. But of course, it's good because the vessel is very small. So after we open and we deploy stent, we look very good scaffold of the stent. But sometimes some position due to the calcified nodule, it does not open good. We must do more post-dilatation. Thank you.
Yeah, thank you very much. And I would like to ask Dr. Quang Lee about this presentation, and then any comment about the tips and tricks in order to perform the PCI for the last remaining vessel. Thank you. Dr. Quang Lee, please.
Yeah, congratulations, Professor Ho, on 3 very superb, very complicated cases. You know, and it was so nicely demonstrated. I think from a tips and tricks standpoint, I liked what you showed us with regards to IABP use and IABP standby versus Impella. I think we have to remember that data with the higher bleeding, etc., is not randomized data; it's registry data and outcomes. You know, we've learned a lot about the management of large bore sheaths with Impella since that data was published. So, you know, we pre-close our Impellas in high-risk PCI, but I think you are absolutely right. Many cases don't actually require Impella support. And most of the time, you don't even require intra-aortic balloon pump support to do many of these cases. I think the difference there is that some of these patients are very ischemically preconditioned. So if they've been walking around with this severe ischemic heart disease for a long time, they will tolerate a lot of stuff happening to it without anything bad happening. The one thing I would say is whenever we part sheaths nowadays, just to have it as a possible rapid upsizing access to put a device in, we have started to move away from leaving even a 5 French sheath. We use ultrasound guidance, we put a micropuncture needle, and we just leave the micropuncture wire in. So it's the smallest possible wire that's sitting in the artery. So that, because sometimes, as we all know, you know, we do a TAVR and the worst bleed is in the 5 French access on the other side. You know, so that's one tip from us. What about Mark? Dr. Benares does very, very high risk cases. I'm sure we would love to hear from him.
So, Dr. Ho, I also congratulate you. These are innovative, you know, very complex cases. You know, the degree of calcification is something that we're very familiar with as well, just with the lack of availability of care here. There's a couple of things. I really appreciate the thoughtful approach to providing flow through the CTO, or at least attempting that in the other case, or thinking about it. I think that attenuates the need for mechanical support when you can provide collateral flow into the area that you're working on. I thought that was very thoughtful. My one question is that the aneurysms are most times atherosclerotic aneurysms, and in what I've found, and I appreciate the question about imaging there as well, and I also appreciate your response about the difficulty in imaging this mid-LAD through severe disease, through tortuosity. It becomes impossible. But I think that the risk of rupture is exceedingly low in these coronary aneurysms, and that most times, because they're atherosclerotic, when the vessel is optimized, the appropriate sizing of the stent actually incorporates the aneurysm, and the stent becomes opposed to the wall of the aneurysm, because that's actually the appropriate size of the vessel. So as I've treated these patients, I've just worked with that in accordance with the surrounding vessel and seen the aneurysm actually completely resolved because that's the size of the vessel. So I have rotablated just regardless of the aneurysm, and I may not have seen what you've seen, but I haven't had any vessel compromise as I rotablate past them, because the rotablator tends to favor the calcium and not go into the aneurysm. And I'd love to hear your comments. It's kind of a contrarian view there.
Yeah, thank you very much, because the time is limited.
Yeah, before we stop, I want to repeat that. Not only you put the coil into the aneurysm, because in practice we when we have the small aneurysm, we leave we don't do the coil, and we only standing across the aneurysm.
Yeah, thank you, Professor Huang. And I think the time is limited, so I think I would like to thank you, Professor Yong, for a very interesting presentation. And then we have to move to the next speaker, that Dr. Professor Nguyễn Ngọc Quang will present about the distal left main bifurcation, and he preferred a provisional side branch stand technique. Professor Quang, please.
Thank you for the introduction, and in a few minutes I will present my talk about the preference to distal left main bifurcation, and I must to the provisional side branch stand techniques. So basically, we have already seen a lot of challenging is PCI for left main bifurcation, and you can see here the impacts of the low shear thread of the bifurcation. So basically, we have a lot of plaque and also the thrombus there, and it can affect a lot for the structure of the carina and also for the bifurcation. For the PCI for left main bifurcation, there is a lot of heterozonetics. So we need to think about the last and mismatch diameter for the left main of the side branch. We also think about the shape of the left main, and we also think about the plaque distribution pattern. So the angle between the LADs and the cert. So what is the distal left main bifurcation? So you can see here that is a classification by Madena 111, 101, or 011. So it's a real true bifurcation. And you can see here the definition of the bifurcation lesion based on the bifurcation club. So they mentioned about the definition of the bifurcation lesion and also the anatomies, and the how to identify the complexity of the bifurcation of the PCI. One thing is important that you should mention about the left main bifurcation plaque distribution by IVUS. So basically, in 90%, you see the plaque involved in the LAD. So that's why the LAD usually is the main vessel for bifurcation intervention. And if I need to put a stent from the left main to the side branch or main branch, the main branch always is LAD. It's not only due to the area the LAD supply the blood, but also involved in the plaque distribution. If you put a stent from the left main into the LAD, in 90% you can control how the plaques are growing up. So for the long-term outcome, you should think about that. So one thing is important, the Quan Lee's already mentioned in his topic, is how to choose the PCI or the care or CBZ. And if you really think about the PCI for distal left main bifurcation, usually the indication only class 1A or 2A is for the lower sanctax. So basically, for the people with the higher sanctax more than 32, cabbage is the preferred choice. So when we analyze this, the study compare the one stand or two stand strategy, you should thinking about this area. And I think that I only discuss about this area with the lower sanctax for the patient. These slides Quan Lee already mentioned, but I need to go a little bit deeper. So compared to 1 or 2 stent strategy for left main bifurcation, you can see here this is a meta-analysis for the 21 trial with quite a good number of cases, and you think that DK class is better and even better compared to the provisional stent. But however, when you see the very clearly about the detail, you can see like compared to the provisional stent, every 2 stent strategy, even the DK class cannot improve the cardiac death, mortality in infarction or stent thrombosis. Only one thing the DK class can improve is the target lesion revascularization. So we can back later on. Another thing is important is the advantage of DK class is only appear when the side branch lesion land more than 12 millimeters. So basically, for the normal and simple distal left main bifurcation, DK class is the same as a provisional stent. They only some advantage if there is a big lesion in the side branch more than 10 millimeters. So we back into the latest data for PCI for the left main EBC main stent. So basically, this is the study came from the Europe partner, and even the Quan Lee mentioned that they did not choose the DK class, but however, we can look more detail about what was going on. So basically, this trial compares randomized trial compared to one is a single stent strategy and with the planned dual strategy. And it is an inclusion criteria and exclusion criteria. In one side, they do the provisional size branch stenting, and the other side, they do the dual stenting by Q load or DK class or T stent. So this is the data on the baseline compared to group, and I think everything is nearly equal. And you can see here about 20% convert from the stepwise provisional to the systemic dual to stent. So this is the main data from that. So in terms of primary outcome, death, MI, revascularization, death, MI, revascularization, cell or stent thrombosis, everything is equal. So one thing is important, like you can see here, this is only for the lower sanctuary. The sanctuary is always lower than 32. So in terms of simple and not complex and not diffuse lesion, DK class, Q load or 2 stent technique is equal like a provisional stent. So we can see here, everything here is also mentioned like the SB lesion length is less than 10 millimeters. So that's why you didn't see very clearly advantage about the 2 stent strategy for this kind of trial. So how about another trial? So if you look back again about some very important trial compared to the 2 stent versus provisional stent for complex bifurcation, like a definition 2 trial. This trial have 20% of sanctuary more than 32. Of course, you can consider like the people might choose the KPIs, but however they choose the PCI. And if you compare all the index, you only see that the number of cases increasing about the MI peri procedure. So in the definition 2, everything different between the 2 stent compared to the provisional stent. Only in the acute phase with the peri procedure myocardial infarction. The other thing is actually is not much different. So even the composite endpoint is better for the 2 stent strategy. However, you can consider that if you can increase the peri procedure MI for the complex bifurcation, you can have a good result with the provisional stenting. Also, when you look back into the DK class 5, the outcome after the 3 years compared to the DK class versus a provisional stenting. So we can see here that actually for the first 1 year, everything is nearly equal. and the stent thrombosis is not different after the 1 year. And if you divide it into the two group, one group is a simple thing, one group is a complex thing. In the simple things, everything is the same. So basically, for the simple left main bifurcation, DK crust is equal like a provisional stenting. And this slide, Kwan Lee also mentions and why it happened. Increasing the TR rate in the provisional stenting just because you did not cover well the bifurcation. So if you have something to cover the bifurcation, the cover the ostium in the good way, you can have the better result. And this one also confirmed by another one like a long-term result after 10 years of the BBK left main registry. So basically everything is the same. So for single stenting with compared to the double stenting is the same. So far you can see here the TR rate even higher in the double stenting. Another important and also the latest data compared to the provisional stenting versus two stenting strategy for the true bifurcation involved in the large side branch. And this one is a Nordic Baltic bifurcation study 5. 4 is number of the patient is 4 to 100, and everything is actually is the same. There is no difference in terms of every criteria index compared to professional stent technique with the two stent techniques. So we can see here the conclusion is in bifurcation lesion involved in the large side branch with ostium stenosis, the routine two stent techniques did not improve the outcome. And another one is also important compared to the provisional stenting. You just simple crossover compared to the side branch opened by the balloon. And you can see here if we just classify into the two arm. One arm is just simple crossover and do the port, and one arm is you do the side branch opening with the kissing balloon. Everything is the same. So basically for the provisional stent, you try to keep it simple, you try to protect the side branch occlusion, and then you have a good result as a two stent strategy. Another kissing balloon inflation on long-term outcome after PCI for distal left main bifurcation in the Excel. So basically for the final kissing or non-final kissing for the one stent or two stent, everything is the same. So we try to keep it as simple as possible for the bifurcation left main. Another one is you try to port or you do the kissing balloon technique. You compare the two sides. You can port first and then you do the side and then you pause again. And the result is the same with the kissing balloon techniques. Another way is sometimes you can do even for the left main is you use a modified J balloon techniques and you try to open the side branch active. And by this result, everything is okay. So basically for provisional for the last side branch, J-swipe for small balloon, you can open, you can keep the side branch open and the long-term outcome is the same. So this is the trial. So back into the basics, how about the pathology mechanism of the left main stent failure? So you can see here, this is major cause and location of the stent thrombosis. And you can see here, the man apposition is a strong hit predictors for the left main stent failure. So if you have the IVERS, if you do the port regularly, you can reduce the man apposition and then you can reduce the rate of the left main failure. For the one stent strategy, you can see here you can put a stent into the SERT or you can put stent into the LAD, and the restenosis SERT is always is prominent. It doesn't matter you put a stent into the LAD or into the SERT. So that's why I can tell you that for the one provisional stenting, you just put the stent from the left main into the LAD, just ignore the SERT, because actually the third restenosis have a very little impact on long-term mortality. Patient may be came back due to another PCI, but it did not have a significant impact on the long-term mortality. So that's why you just put a stent from the left main to the LAD, keep it open, just ignore the SERT and everything is fine. So every evidence from the trial, from the experimental support for the provisional stand philosophy. So that's why in terms of European bifurcation club, they mentioned that one stand strategy is recommended for the vast majority of the bifurcation lesion. However, you need to make sure that you reduce all the factor can impact for the long-term outcome. First of all, you need to disturb while crossing before the final kissing of for do anything. You can see here if you go while in the proximal crossing, and then you cannot cover the whole the whole ostium of the third. And you can see here if you go wide into distally, you can cover the third ostium, and then you can reduce the third restenosis. Another thing is how to do the optimal port techniques. It's not only like you just put a balloon there and you open it. So if you put the balloon a little bit further down into this into the distal vessel, and then you can make the overstretch here, you shift the carina, and then you can make some complication later on. If you don't touch the carina, and then you might have a proximal stand edge dissection, you also did not cover the whole ostium of the side branch, and for the long term, it may got a stand failure. So that's why the optimal port is very important. And here you just before the carina, at the carina before you divide it into the distal part. And in this way, you can have an optimal part. You cover everything. You make the malposition reduce, and you maintain for the long-term outcome. So to conclusion, if I need to choose, I will continue to choose the provisional side branch stenting techniques. And actually, it's no two bifurcation are identical, and you need to customize approach for every patient, depend on the vessel size, angle, important, and extent of DZ in the side branch, especially for the case with the side branch more than 10 millimeters. And however, provisional stenting for distal left main should be the preferred strategy when feasible. And this strategy is appropriate in majorities. I think I can tell you like nearly 80 to 90% of the true and non-true bifurcation as the left main, and try to keep it as simple as possible, especially for the optimal port. Sorry, it is a port rather than final kissing. Final kissing is okay, but you need always end up the procedure with the port. And of course, you need to think of the backup plan for two-stand strategy, especially for bifurcation with potential side branch acute close. For example, like a heavily calcified, severe angular side branch, or side branch lesion more than 10, and also the suboptimal after pre-dilatation. So this is my choice, and thank you very much for your attention.
Thank you very much, Professor Kwang, for that phenomenal, very detailed, very elegantly argued presentation. I thought it was superb, and I completely agree with you that the provisional stenting technique should be the default strategy if it's a simple, more straightforward lesion. On our side, I don't find it's 80 to 90%. If we truly image on both sides, I find our proportion of true non-complex, left main is lower than that. We probably get like 60%. And one of the beautiful benefits of using a provisional technique is obviously the speed at which you can do it and the simplicity. Once again, I think the main problem is that people are not potting regularly, they're not doing it well, and they're not imaging. And that's why I think this is one of the biggest difficulties with comparing all of the studies that we've seen. It's not mandated intracorneal imaging. It's not mandated what you do, what the exact strategy is. This question of crossing distal cell, etc. People are just not doing this consistently. We really need studies where the discipline is very, very high to truly understand the difference. What I think has definitely emerged over the last few years is that pot is probably, you don't need that final kissing. I used to be a final kissing all the time. I think over the last few years, it's becoming clearer and clearer as I image more as well, that, pot is a very nice way of doing it. I wanted to ask a question. do you think the type of stent that you use matters? Because, you know, some of the trials were very specific. We use Zion stents. Some of the trials are very loose. You know, you can use whatever stent you like. I'm not sure if the data is interchangeable, and I wish people would be more disciplined about that question. You know, yeah. So, what are your favorite stents, and you know, do you think it matters?
Yeah, I think it's really matters just because there is a mismatch between the left main and LADs or the cert. So that's why we need some stent can a little bit like overexpand and did not change very much did not deform the stent platform. So that's why for me, usually I only choose some kind of stent for the left main. For example, like Zion or Onyx or Resolute is something like we can a little bit like a belief on the capability of overexpand. So I think that port is very important for to make sure that you can reduce the mana position and to make sure that there is no mismatch, no gap between the stand and the vessel side. Thank you.
And then I think I had last question for my Vietnamese colleagues. Is there drug-coated balloons in Vietnam or no? Or do you have access to?
Yes, we have quite a few, and so that's why for some case we try to apply the drug coating balloon for the side branch.
Yeah, exactly. Could I ask the other Vietnamese panelists, do you have you done the same thing using the DCB for the side branch in a provisional technique? And what has your experience with the results been? We don't have it in the United States, so we don't know what happens when you do that.
Yeah, I think that for the side branch, we don't use drug-eluting balloon. Yeah, always we don't use. Yeah, because yeah, we think that yeah, only the side branch is very small, and we do the kissing balloon, final kissing balloon. We use the drug-eluting balloon. Otherwise, we don't use drug-eluting balloon. And I have the question to Professor Quang and Dr. Quang Lee. In some patient, when the circumflex is very big and the patient had the small LED, could you put the stent from left main to circumflex? This first question. And the second question is some interventionists normally when the side brain is not have not lesion, they put the stent and don't do the final kissing balloon, because final kissing balloon is for long term they will cause the balloon will cause the restenosis in the side brain. What do you think, Professor Quang and Dr. Quang Lee?
If I answer first, and then the first question is, yeah, it's true. Sometimes when you have a very big cert and then you consider like you put stent from the left main into the cert, it's okay. But one thing you need to remind that for the ostium, the cert for long term always restenosis. So that's why if you do like that, you need to do the post dilate very carefully with the non-compliant balloon for the cert ostium to make sure that everything is okay. And then for long term, it can save for the patient like that. Second question is the final kissing balloon, and I totally agree. And Quang Lee already mentioned that we prefer the port. You do port properly, and then long term outcome is better. Thank you.
Yeah, I also totally agree with Professor Quang. You know, I think the main thing when you think that the LED is smaller than the circumflex, always image it, because sometimes it's all diffuse disease and it is not truly smaller than the circumflex. You can sometimes get caught out like that when it's just diffuse atherosclerosis. So you have to plan that out. But to your other question, we've moved away from final kissing balloon for the most part and simply use POT for optimization. I think we are running very far behind, so I think we need to move forward with our program. I'd like to start by introducing the next speaker, who's going to talk to us about tips and tricks in left main intervention. We have Dr. Mark Bienares from the Loveless Medical System in Albuquerque. He's an interventional cardiologist at New Mexico Heart Institute and the director of the cardiovascular service line. He has a special interest in STEMI systems of care, and New Mexico is a very rural state. So especially with regards to the delivery of STEMI care in a very low density population region. He's an expert coronary interventionist and really does phenomenal cases. So we look forward to learning from him.
Great, thanks a lot, Dr. Lee. Can everyone hear me?
Yes.
Okay, and you can see my screen.
Yes.
Okay, and Dr. Ho and Dr. Tuckman, thank you very much for the invitation to join for this first time. This has been a great, really comprehensive meeting thus far, and I'm thrilled to be part of it. Presenting the tips and tricks lecture is always a challenge because you synthesize everything that everyone has said. You try and agree with some things, disagree with some things. And I think that I hope that this is exactly that. I think it's fascinating, the lessons that we've heard, the themes that we've heard throughout this thus far, the importance of imaging, the importance of lesion preparation, the importance of POT. And I think that each of these goes together. And it's been also fascinating reviewing the data where these individual things have been left out with, as Dr. Lee has alluded to, the deficiency in imaging, and somehow we're able to recommend POT without imaging. And there seems to be a lot of guessing. And so, we want to have a very comprehensive approach to left main PCIs to ensure outcomes. I also really appreciate the approach here of an argument for single stent technique from Professor Kwong, and then the later argument for two stent technique. And I want to really highlight Dr. Kwong's or Professor Kwong's excellent lecture on the single stent technique because it challenges what my basic approach is. And so I think you did a great job of that. I really appreciate the benefit of single stent technique when the lesion length in the side branch is less than 10 millimeters. And I think that's a very, very important thing to highlight. And then the importance of POT afterwards. I'm going to present a little bit of a different approach. Left main, I'm going to go over this comprehensively and then end with a case. It shouldn't be terribly long, but we want to always consider the patient first, the hemodynamics, the anatomy, and the complexity of the lesion before launching into the PCI. And the hemodynamics, of course, are going to help us to risk stratify any high-risk PCI. And the assessment, I would always argue in favor of assessing LV, filling pressures, and before going into a left main PCI, and then deciding on the need for hemodynamic support versus medical optimization or waiting on that patient. You always want to assess whether the patient is needing emergent management or can delay for medical optimization prior to launching into left main PCI. And then the anatomy, we want to decide, is this an ostial mid-body or distal stenosis, which bifurcation strategy that we're going to go on. Where is the largest branch? As we talked about, is it appropriate to use two stents or one stent if the circ is the largest branch? As Kwan also discussed, the importance of imaging pre-procedurally in the small LAD, because we can be duped in thinking that it's a very small branch when it actually has extensive circulation and is a large branch that's being disguised by diffuse disease. Is the patient left dominant? Is there a ramus present? All these are questions that need to be answered prior to launching into the left main PCI. And then which vessels actually need to be wired and fixed. And as Professor Kwong discussed, that does have to do with the presence and the length of the side branch disease. And then does the distal bifurcation stenosis involve the osteo of both branches? And then complexity, what will complicate the PCI? I think it's very important to bring in all data that we have, and then to bring in all of our experience to anticipate what could happen. What could happen when there's calcification? What could happen when you have more distal disease? Calcification is something that will be a problem if the lesion's not prepared effectively. I'm eagerly looking forward to being able to do intracoronary lithotripsy for lesion preparation because that will make a difference in left main, and I appreciate Kwan's comments on that. And then involvement of other disease, as we saw in Professor Ho's great case presentations. Management of diffuse coronary disease is hard, and how you decide the order in which to tackle these. Choosing which artery to perform an atherectomy on first. I have never attempted to have two wires in and choose one of the vessels with a guide extender, but I guess that's possible. But I think that most of us will do an atherectomy using one vessel, and the side branch typically is perfectly safe, or actually has better flow after performing atherectomy on the main branch. I choose to perform DK crush on nearly all of my bifurcations. I think that the insurance no closure of the side branch is worth it, but I really take to heart the comments on the nature and length of the side branch disease for single stent technique. Kissing balloon pre-dilation, and then typically working on the left circumflex ostium first is my standard approach, with then pre-positioned left main to LAD balloon for the crush, and then left main into LAD kissing balloon post-dilation. So just kind of the description of DK crush from my perspective. And then IVUS before and after. IVUS before for stent planning, stent sizing, IVUS post-stenting for POT, and then for ensuring that there's adequate expansion and apposition of the stents. So I present a patient here to you all to discuss who I think employs a bunch of different tips and tricks. So this is an 84-year-old gentleman who I followed for years. I had attempted to refer him multiple times for CABG due to the complexity of his anatomy, and he was turned down each time. I think I sent him to 2 different surgeons, and he had just had deficient conduit. He had an occluded left subclavian, limiting the ability to perform a lima grafting, and he had poor veins. They've been used for peripheral bypass in the past. And I had been managing him conservatively, and he was failing medical management as he had accelerating symptoms and exercise intolerance. Interestingly, he had a normal EF, and his pre-intervention LV pressures at the time of the intervention were great. And so this would have been a very, very difficult person to support hemodynamically with any device. We discussed right axillary support, but that vessel was horribly diseased as well on a CT that we performed. And so we just discussed the risks of doing nothing versus the risk of PCI. And so you see here just critical calcified left main. You see an LAD CTO, and then he does have ostial left circ calcification as well. And I don't believe that this would be appropriate for single stent technique due to the horrible calcification of the left circumflex ostium as well. And so I opted to do, here's the left circumflex ostium is a very unfavorable angle and very difficult to wire. And you also see that there's bifurcation LAD diagonal disease. So pretty difficult lesion to tackle. And he has an RCA CTO also that is collateralized into the RPD from the left circumflex. And so this is a patient that is going to be a very complex approach. So the planning, I like to stick with the plan and kind of mull over the diagnostic images before just launching into this, because in this case, it was very, very important to decide exactly the stepwise fashion to fixing this gentleman's complex disease. I pretty much will always use 6 French. I don't think that 7 French is necessary, and I'd love to hear comments on that later. I standardly am approaching things from the distal radial artery at this point, just because I've had too many proximal radial artery occlusions. So I'm using distal radial as a standard approach. and I can size up to a 7.5 with a sheathless guide from the distal radial when absolutely necessary. But again, I think that 6 French is adequate for nearly everything, except for large rotablation and simultaneous kissing stents, which I never employ. The approach here was to attempt to wire the LAD CTO, and then if that was not able to be wired, to just work on the left main bifurcation. I brought a microcatheter to the mid LAD and then was able to cross without too much difficulty into the distal LAD in exchange for a rotofloppy, and then did atherectomy of the left main to the distal LAD, PCI of the mid to distal LAD back to the diagonal, and then remove the LAD wire. And then wire into the left circumflex with microcatheter and laid down a rotofloppy. Atherectomy of the left main to the left circumflex, and then DK crush approach to left main bifurcation. And then rewired the LAD, and then proceeded with DK crush approach. So, and then IVUS for post dilation. So here's the, after laying down the rotofloppy, this is the rotablation to the mid LAD after rotablation of the left main. And here is after the initial stent in the LAD CTO up to the LAD diagonal bifurcation. Then the diagonal is threatened due to the osteal disease there. So I decided at this point to then proceed and not to get into any proximal LAD. And I hadn't done anything except for do atherectomy of the proximal LAD. And so I concentrated then on the circumflex and wired into this after pulling the LAD wire. And this is the atherectomy of the left circumflex. And so then the question is, do we use single stent after atherectomy? And I would never attempt to do that. And I think the complexity as well as the length dictates 2-stent technique here. This is the initial, after kissing predilation, this is the initial stent in the circumflex with the prepositioned balloon for crush. And then the predilation of the LAD. And then attention back to the LAD with provisional, this is a provisional side branch approach to the diagonal, which ended up staying open very, very nicely. So I left that without a stent in that. And then this is a stent into the left main, and then final kissing. I did not, I imaged this and did not do pot because there's not enough stent in the left main. So it's probably an error on my behalf that I probably should have brought the stent back further so I could actually do a single balloon pot. But I think that imaging precludes the absolute need for pot when you have great apposition in a left main that's actually quite size matched into my LAD. And so then we have the final image here, well opposed stent into the LAD CTO with a very patent left circumflex. There's some calcification left behind the stent in the left circumflex. But again, complete revascularization with essentially a left dominant system that also collateralizes a codominant right coronary. He's been asymptomatic and exercising and is doing great. So in summary, I think that it's very important to have an organized approach to left main, considering the hemodynamics, the anatomy, and the complexity prior to the procedure. Always engaging heart team approach. Many times when I find ad hoc left main disease, I'll call a surgeon who will come and we'll actually have a heart team meeting and then proceed with the high risk ad hoc left main PCI. And then I think it's very important to always ask if I am actually the one to do this procedure. Never fear asking for help and collaboration. We have in my group 4 interventional cardiologists, and we're always teaming up for these patients. I think that radial and 6 French should work for nearly all, if not all cases. IVUS before and after for stent planning and sizing and to ensure apposition and expansion into guide pot. And then atherectomy is very important with left main calcification for optimal stent placement. I use double kiss crush for bifurcation stenting, And then I always end with the kissing balloon post-dilation, which is much more important for two-stent technique than it is with one-stent technique. So again, thank you so much for the opportunity to be here, and thank you for your attention. I'd welcome any questions.
Thank you, Mark, for that thoughtful and very carefully laid out, very organized approach to your cases. I was a little fascinated by what you said about the distal radial approach. How long have you been doing that for? And we've seen the theoretical literature suggest that there is a reduction in radial artery occlusion. Have you actually seen that now that you've adopted distal radial? And are you also using distal radial for the right wrist and not just the left wrist where it initially started as well? What is your experience?
So Quan, I'm kind of accumulating my patient volume here and following outcomes right now. It's I'm preparing it. It's excellent. I've done 2,000 cases through distal radial at this point. And I'm using them. I'm using right and left. I'm using it as the primary access for everything, STEMI and everything. And the results are unbelievable in terms of the outcome of radial artery occlusion. Radial artery occlusion becomes a big deal in bypass patients who have many trips to the cath lab, in young patients with coronary disease who are going to receive many cardiac catheterizations. And if we believe in the radial data, then we really need to do everything that we can to avoid radial artery occlusion, including adopting distal radial. I have in my follow-ups, which I've followed up about 500 cases at this point, I have 3 occlusions, which is remarkable compared to the proximal radial artery occlusion rate of 5 to 10%.
Yeah, and
I started doing it simply because I got tired of my patients coming and saying, "This is hurting. What's going on?" And you feel their arm and they have no pulse there, and it happens, and it makes a difference.
Yeah, no, that's fantastic. Can I ask my Vietnamese colleagues, how many of you are doing a lot of distal radial artery, and what is your experience so far?
I just mentioned that we just jumped in this area about 1 year ago. So basically, I think that distal radial approach is very suitable for our patient because they don't complain much about the pain after the procedure, and also the caring after the procedure is easier for the nurse and for the staff in the ward. And when we did the basic study, compare the diameter of the distal and proximal diameter of the radial artery based on the Doppler and compare to the angio, and everything is the same. So basically, it can jump into the distal radial artery quite easy as a proximal. Just you change your mind and change a little bit in the protocol, and everything is go fine. And we continue to do the complex case to the guiding catheter through the distal as usual. And only few cases, even we can upgrade into the 7 French guiding catheter, and it's safe. So I think that for the future, it doesn't matter left or right hand, distal radial artery is the preferred approach.
That's fantastic. Professor Ho, did you?
Yeah, I really no experience about the distal radial approach, but I often use brachial artery for some case with we need 7 French, 8 French catheter, but we cannot go into femoral artery. We use the brachial. I think very comfortable and convenient. It can go easily. And we can do some case with the trifurcation, quadrifurcation of the left mac. About the distal radial approach, I have no experience.
And Professor Quang, are you using the dedicated Merit vascular closure device? Mark, are you using that as well, or are you making some different compression device?
Yeah, I use that distal radial band from Merit.
from
Yeah,
Eric?
we in our lab we just do the manual compress. We change a little bit just due to the cost. So
Yeah.
so it is safer. No, it's more convenient for us to take care about that.
Right, Mark.
I think that's
cardiovascular.
fantastic because it is possible. It's way more possible to do that than for proximal radial. And manual compression works on the distal radial, and you can discharge the patient with a compressive dressing in place. And it's a perfect, the snuff box is a perfect place to cradle a curled up 4x4 with the compression dressing right there. And you can compress it really well without any occlusion. So I appreciate that approach very much.
Yeah, Mark, as the cardiovascular service line director with 2,000 cases, that is a lot of saving.
Yeah.
One of the things and I appreciate what you shared with regards your approach with the standardized DK crush, technique. One of the things I actually found that's the most important as a tip and trick is just having a good library of ultra low profile balloons. There was a time when I just had treks and sprinters on my shelf, and there would be a percentage of cases where you wire through, and no matter what you did, you simply couldn't get the balloon down to inflate to begin to get your kissing done. And ever since we got the Sapphire 2s, etc., onto the shelf, it's made a huge difference. I think that's a good tip.
We have Takeru balloons, the Tsurumi Takerus. And those are incredible crossing balloons for they I think have the lowest crossing profile. They're high priced, so we have those just as our non-contract balloons for exactly that case.
Yeah, in Vietnam, what is your ultra low profile crossing balloon that you use?
We have a lot of kind, and actually we try everything. Because sometimes it depends on the stock, and just because our patient is a lot, and then actually we try every balloon we have in the stock.
Okay, yeah, I mean, and last comment before we move on, I think seeing the two approaches here, very provisional stenting, one stent technique, 90%, and then 100% DK crush. I think ultimately I suspect that the outcomes in the long run are also very much dependent on the operator, right? If that is your favorite technique and you do it well, you probably can overcome some of the differences in outcome because you do it well. I think it's very dangerous to confirm our biases, where I say, I'm only a provisional guy and that's the best way, and you don't go and learn the other way. And you start to develop a mental block where you just don't want to do it because this other way is better. You have to know both techniques, all the techniques, and you need to know when exactly the other technique is a good technique to apply. And you have to be comfortable jumping back and forth between the two. I think if you do a good job, your outcomes will probably overcome any differences between techniques. Okay, we have quite a few more presentations to go and not much time left. I think we only have like 40 minutes on the clock. So I'm going to jump forward and invite our next speaker, who is Dr. Do Quang Huan, to talk about distal left main bifurcation. I prefer the two-stent technique. I think no better segue than that to talk about the two-stent technique.
Dr. Huang.
Yeah, I will share my slide.
Yeah.
While we wait, Mark. No, not yet.
Can you see my slide?
Not yet. Not yet. It was about to go live and then it stopped.
Oh, yeah, okay.
Okay, we are waiting.
Yeah. I received the program.
Yeah, it says that we are screen sharing, but we don't see any slides. Did you select the right screen to share, or are you in double screen mode? Sometimes if you're in double screen mode. Does anyone else have a copy of Professor Huan's slides? So we can, maybe somebody else can play it. Oh, yes, we see it now. Yes, we are in presentation mode now.
Yeah, only yesterday night I received the program, and I know that today I will present the presentation. For digital lab main bifurcation, when I prefer intentional two-stand technique, all we know that the lab main bifurcation is very dedicated, very complex lesion. Because the mismatch between lab main and the side branch, ILD and circumflex, and the technique we choose one stand or two stand technique depend on the lesion of the side branch, the diameter of side branch, and the severity of the lesion. When the side branch is not had the lesion, normally we choose the single stand technique, provisional stand technique, and we do the POT for the final. And for the side branch, when the side branch is very had the lesion, long lesion, calcified lesion, complex lesion, normally I prefer the two-stand technique. For the patient, one patient, 32 years old male, hospitalized for unstable angina. The risk factor is smoking, hypertension, and dyslipidemia. When we did the angiogram, we see that the patient has the distal left main stenosis with the Medina 111. First, I tried to pass the wire through the LED, and I could not pass the wire through the circumflex. And I use the big balloon to pre-dilate the LD with the intention to pass the wire through the circumflex. And all we see that the circumflex LD is very calcified. And when we did the balloon dilatation, the circumflex, the sheep plug occlude the osseum of circumflex, and the pressure of and the blood pressure of patient drop. What should we do? We transfer the patient to operating room, or we keep doing the procedure. I try to use the wire to pass through the osseum of circumflex, but the wire go to the ramus, intermediate, and then I try to wire through the circumflex to rescue the circumflex. I didn't. I cannot do that, and I use all the balloon to dilate the trifurcation again, and this time I could see the osseum of circumflex and with the plug ship to the osseum of circumflex, and I use the Couset catheter to pass the wire through the circumflex, and very difficult to pass the balloon through the osseum circumflex. I use the Corsair to pass the wire through the circumflex and do the kissing. And after that, we see that in the mid LED, the lesion are very tight and calcified. Even though with the balloon, we could not open the lesion. And finally, we can do the rotablator and put the stand from the mid LED to the proximal of LED. And now for this lesion, what should we do? We do the single stand or two stand technique. For the left main bifurcation, all we know that, as the Dr. Wang Li and Dr. Mark already said, Dr. Quang said that for the complex lesion, stenos are more than 70%, and the length of the lesion of the side brain more than 10 millimeter. Complex lesion, we for two stent technique is better. All the criteria, moderate to severe calcified lesion, multiple lesion, and the angle of LD circumflex is not quite good. And the main vessel with the referent vessel, very small, main vessel length is more than 25 millimeter. Two stent technique is better. And as we mentioned above, side brain, when the side brains are the size of side brains is less than the main brain, and the angle, wide angle, with the decay curve better than the culotte. The decay curve study 1, 2, and 3 compare curves and decay curves, provisional stenting and culotte technique. We know that the maze TLR, TVR is less than in the arm of decay curves than all the technique. And therefore, I choose the decay curves for this patient. I put the stand to the circumflex, and after that, I put the stand in the form LD to the left main, and final kissing, and is final result. What message we could take home? Left main PCI is challenge procedure. With the complex lesion, two stand technique is better choice. Side brain stand first, and all the technique, for example, decay curves, culotte, T or TAP, depend on the lesion. And if we do the iBurst, OCT is very helpful for left main PCI for up position. Yeah, thank you for your attention.
Thank you for a very excellent presentation from Professor Đỗ Văn Huân. By now, I'd like to hear some comment from the panelists. I think, first, in my opinion, the simple thing we can manage by the simple way, and the complex thing we must manage with the complex way. And the problem is the thing between the simple and complex is in the middle range. We choose the provisional stand technique, or we choose the intentional two stand technique. So I like to hear some comment from maybe Dr. Quang Li first.
Yes, thank you. Yeah, I agree with you. You know, obviously we adopt our techniques to whatever we are confronted with. And I think the point I was trying to make earlier as well is that we have to be familiar with all of them. You know, we don't adopt one technique because we don't like the other technique. We adopt the technique because it is the right technique. I thought that was a great bailout of a very difficult situation, and a creative way of using the double lumen catheter, etc., to get past. But I think you know, it was quite clear that there was a high risk of the event occurring in the first place, given that it was very difficult to wire to start with. So I suppose a thought would be to adopt all the techniques that you use to get out of trouble up front, and make sure that that protecting wire was there before getting to it. One thing I've also found is that sometimes to reopen it is to just do a pot. It's quite surprising that, you know, when the side branch goes out, sometimes if you just pot, it starts to give you more opportunity to open up again. And I'd love to hear whether my Vietnamese friends, you know, whether people will also use that technique to try and reopen the side branch. Like, what is your best strategy when you find that the side branch is now, that you had not protected, is now occluded, I suppose?
Okay. Can you give your opinion, Dr. Ngô Minh Hùng?
Yes, thank you very much for inviting me to have the question for this. You mentioning a lot about the pot after you put the stent, and then you put the you do the pot for the procedure. So how do you do the pot? Because you based on the marker of the balloon, or you use the solder of the balloon? Because the balloon is different between balloon to balloon. So the solder is quite different from the distal marker and the distal border of the balloon as well. So how do you do that? Thank you.
Yeah, I think that's a very, very important point, that not all the balloons shoulder is where the markers are. They vary between your balloons. So you have to know your balloons, right? We always use non-compliant, first of all, right? You cannot use a compliant balloon because they will change shape. And it's always smart to err on the side of being more proximal than you need to be, to see how your balloon behaves first, and then move your balloon a little bit forward if it's too far behind. It's okay to move forward. It is not okay when you overshot already, you know. And I go up slowly on the atmospheres and watch the shape, you know. And you always want to use views that separate the two vessels in the most orthogonal that you can find. Because sometimes if you are using the wrong view, you think you are not where you think you are, and then you are also in trouble.
Yes, thank you. That
Okay,
I also do in clinical practice. Yeah.
And I have the question to Mark. When we have the very tight distal labment and very difficult to pass the wire to the side branch, what should you do? Or you could not pass the wire for the first time? Yeah, what should you do?
So your situation was very difficult, because I think I agree with Dr. Lee that the techniques for bailout, you know, I think that every technique should have been exhausted prior to the ballooning, because it was a very, very high risk for occluding the side branch. And so you know, the other thing that hasn't been discussed that I've used in situations like this is the supercross angulated microcatheter. That's also useful, and I think it would be useful in the same way that that twin pass catheter is useful for positioning your side branch wiring. The supercross are multiple different angles, and you can even wire retrograde into a greater than 90-degree side branch. And I've had to use that to wire into very unfavorably angled circumflexes before. The other thing to bring up is that when the side branch can't be wired, and it's a very large, important side branch, or if it's a dominant left circumflex, there is the possibility of just abandoning prior to the predilation and discussing it with a surgeon, then, unless the person is absolutely not a surgical candidate. So those are my two comments on that.
Okay, thank you so much, Dr. Mark Pina.
And the last question are for the with the question of Professor Hùng. I think some doctor when put the stent on the labment, they put to the ostium of labment, and therefore when they do the last POT, it's not close dissection on the labment. What do you think? When you put the stent on labment, normally you put to the ostium of labment, even though ostium of labment has not the lesion.
Yeah, Professor Hùng, asking me about the standing. You hearing me?
Yeah.
Yeah.
What do you think, Dr. Mark?
Oh, so that was actually my criticism in my case, was that I didn't extend my stent far enough into the left main on that case that I presented to actually facilitate effective pot. And so I think that I don't know that it's necessary with a long left main to extend the stent all the way to the ostium, but I think it is important to extend it more into the normal vessel than you would otherwise in any other PCI, just to optimize pot and to make sure that you're well opposed with this with a size mismatch.
Okay, thank you so much, Dr. Mark. And I think that certainly we have many things to discuss to exchange our experience, but by now right rather late. So we move to the next presentation. I would like to invite Professor Thạch Nguyễn with your presentation.
Do you see my slides?
Not yet.
We did for a short while. Then we can see them now.
You see now, right?
Yes.
Okay. Today, let me speak in Vietnamese. Thật ra thì là in reality, the young intervention cardiologists did very well. They did a lot of difficult cases. So impressive. Now, my question all the time is, why and how? When we talk about left main, why is there a lesion at the ostium at the left main? And here we see the flow at the aortic root. So these the four pictures, they are in sequence. And here the image of the coronary angiogram recorded at 15 images per second. And at the picture A, we see the aortic root is completely filled with contrast and the aortic valve is closed. Now, in picture B, we see that the aortic valve is open just a little bit, and we see the flow from with the white arrow. We see the flow coming from the left ventricle to the aortic root. And in C, we see better systole, so the blood moves forward, and D, we see move forward. But clearly, we see turbulence here in the aortic root. And this is normal for the aorta. In the past, I used to say that turbulences causes lesion in the coronary artery. So in my question is, now at the aortic root, we have turbulent flow. Why the flow become laminar in the left main? Here it is. The flow started with at the ostium, entrance, and then slowly developed to laminar flow. Here it is. It is an experiment, and we see that the area with cavitation is right at the border of the ostium, and this is where we have the osteo lesion. So my question is, why the patient developed osteo lesion in the left main? I use these two pictures to show that in the right coronary arteries, the majority of lesion in the proximal segment of the right coronary artery at the ostium, the majority of these arteries they have abnormal origin or abnormal configuration of the proximal segment. So I suspect, I don't have the evidence, but I suspect the reason for the lesion at the ostium is also due to coronary anomaly at the ostium, number one. Now, why there is lesion in the mid left main? The lesion in the mid left main, it is if we use a CFD, computational fluid dynamics study, and we see that in picture C here. If the length of the coronary sinus is short, then we have the lesion in the inferior part of the mid left main. If we have the length of the coronary sinus is long, then the lesion, it is at the superior border of the left main, at the mid segment. And here we see in picture A and B, we have here very long length of the coronary sinus. But in this picture, the length of the coronary sinus is very short. So I just mentioned that because this is I'm doing research and I would like to share my experience and my results. So far, I don't have strong evidence how to find the cause of the lesion at the ostium or at the mid segment. Now, what about the lesion at the distal left main? Why the patient develop all the time lesion at the proximal segment of the circumflex at the outer curve? And here it is, here's the flow from when the flow have to go around a curve at the exit shoulder. The speed you have, because there's low speed here, so there is circulation, recirculation, and subsequent turbulence, and this is the cause of the lesion at the proximal segment of the circumflex at the outer curve opposite to the carina. And here it is one of the clearly picture of his one here, the left main, LAD, circumflex, and recirculation here with stagnant layer and later turbulence. And this is the cause of the lesion at the proximal segment of the circumflex. This is why when we do a stent, and we have to think about this area, and I remember Dr. Do Kwang when he mentioned all the time, we have lesion at the, to do or not to do, stenting there, we have all the time restenosis. So how do we solve that problem? It is in reality here we have, in picture A, we see it is a whole artery full with contrast, and we continue to record. And at that time, we have the blood coming in here at the left main. We see right here in A. And then we see in B, the blood go further. And in C, even the blood is at the LAD, and we don't see the blood at the circumflex yet. The flow going to circumflex is 0.06 seconds later. And here in this view, we see clearly that the blood begins to enter the circumflex, but at the carina side, not at the outer curve of the proximal segment. And now we see at the end, we see that even blood go down to the mid circumflex, we still have one area with stagnant flow. And this is the cause of the lesion for any patient with left circumflex. And here it is, look at this one. Let's say in this case, we see that the osteal lesion of the circumflex is the most common lesion. Many times we look at the patient, we say, yes, everything is okay. But in fact, there is all the time, there is a lesion at the outer curve at the proximal segment of the circumflex. And the cause is due to recirculation and layer in this area. So this is, I have a patient who is a hydraulic engineer. So usually after I finish seeing him, then sit down, I told him about my problem in coronary arteries, hemodynamic studies, And he explained everything from the engineering point of view. I just saw him a few weeks ago, last week. And here it is. He mentioned to me, I asked the question, why we have lesion in here? And he mentioned that because the blood going this way to the LED is a normal way. When the blood had to make a turn, it takes more time, more energy, and need to have higher speed. This is why, and I somewhat I agree with that. Let's say when you drive a car in the highway with with fixed speed, this is the time you use the least fuel. If you want to change, make a right turn, in the US you make a right turn, then you have to go slow down, make a turn. At that time you use more energy. If you take a left hand turn, you use more. So this is why this is what I'm doing now, looking at that story. So what are my research project in bifurcation, special bifurcation left main? Number one is an abnormal angulation of the left main ostium is the cause of the osteo left main lesion. What the abnormal flow at the entry of the LAD circumflex? If we restore the normal laminar flow at the bifurcation lesion, do we prevent future in-stent restenosis? Now, let me show one case. Now, I saw all of you did beautiful cases. You did the left main, did the bifurcation, and you did, but the question it is, did you do a good job for the patient? How is the long-term in-stent restenosis? Now, see here it is, I have a patient. The patient has a severe osteo lesion of the LAD.
Iceberg.
Osteo lesion of the LAD. And here it is, the flow, the blood go in, and you see the blood, the primary flow go to the ramus intermedius. And here we see the stagnant flow at the inner curve of the LAD. So here's a lesion with the wide in the LAD. And here's the lesion after stenting. Look beautiful. Very nice. So what happened 2 years later? Again, this one, you see the flow, beautiful. And the flow is not primary to the ramus intermedius anymore. The laminar flow go from the left main to the LAD. And this is how we don't just fix the anatomy, we correct the flow. And this is, I think, this is the new way of thinking about coronary arteries. You see this one? Here I put the stent in the ostium of the LAD. No problem with the ramus intermedius. And look at the circumflex, how beautiful it is. No problem with the circumflex. It's not because we fix the anatomy. We don't do cosmetic surgery. We correct the flow and we be sure the patient has laminar flow for the lesion. So now the question is, I mentioned that we talk now about the flow. Is this strange for us to check the flow of the coronary arteries? Now let me tell you about cardiac surgery. The surgeon, after repairing a mitral valve, what does he do? He closes the heart, stop the heart-lung machine, let the heart pump normally, and do a TEE, and look at how the valve operates. Is there any problem? Any regurgitation? If there is regurgitation, if the valve does not function normally, they have to put the patient back on the heart-lung machine. repair the valve again. And after finish, stop everything, restart the heart, and check it again. Last week, I have a patient who had mitral valve repair and aortic valve replacement. They did that kind of exam operation 4 times. Check the valve, stop, restart the heart, check the valve, stop, fix the valve, restart the heart, and check it again. And this is why today I mentioned that we don't do cosmetic surgery. We fix the valve, we fix the anatomy, and we check the function, the flow. And this is my message. And this is, I share my research. It's not, I'm very impressed with all the work of all the cardiologists from Albuquerque, from Tucson, and from Vietnam. And here is my message. Number 1, I strongly believe the lesion as an ostial left main is due to coronary anomaly. Number 2, we have explained the lesion at the mid segment of the left main. And number 3, last question, we are not cosmetic surgeon. We fix anatomy, but we want to be sure the function, the flow is beautiful and laminar. Thank you very much.
Okay, thank you so much, Professor Thạch Nguyễn. I think when I beginner in interventional cardiology, when I see one lesion with the stenosis lesion, I like to open to help the patient. But after a few years, the patient come back more and more with the in-stent stenosis. I recognize that the interventional cardiology, cardiologists do open the stenosis lesion. It looked like we managed the tip of iceberg. The problem is the mechanism and what made the atherosclerosis formation and maybe hydraulic mechanism. Look like Dr. Thạch Nguyễn have presented. So I like to hear some comment from the Vietnamese panelists and American panelists for your presentation, Dr. Thạch Nguyễn. Maybe Dr. Nguyễn Ngọc Quang. Professor Quang.
Professor Thạch Nguyễn, thank you very much for the great talk as usual. We're really impressed by the way we consider the mechanism for restenosis. So this is open the new area for us to consider again, back and forth to consider how to minimize the restenosis risk for the patient. So back into the implication for the clinical daily practice. So the question is, if we put a stent and how we change the flow by the stent, and is it any different between the big and the smallest diameter of the stent impact on the laminar flow? So I think it is really important, because sometimes when we do the PCI, we try to post dilate as big as possible, but actually if the bigger stent can change the luminal flow in the different way, so we need to think again about the way we post dilate the stent. Thank you.
Okay, thank you, Dr. Wang. What do you think, Dr. Mark? What do you think about the role of the hydraulic mechanism in the formation of plaque, atherosclerosis, and in in-stent restenosis?
You know, I think it's really a compelling thought, and you know, what popped into my mind, especially when Dr. Kwong was just talking about the post dilation, is a lot of times the flow abnormality posts when you see an angiogram of a patient who we've stented in the past, the flow abnormality will be in the area of stent, right, where you see contrast hang up within the stent and not in any other portions of the vessel. So, you know, I think that the concept of provision of laminar flow with our stents is an important one to prevent restenosis. For that very reason, It would be an interesting study to look at flow abnormalities within a stent and follow those patients compared to patients who clear contrast immediately because of laminar flow. So, I mean, I think that's a great topic for research to see who restenosis.
Hello, Kwan. You are a big professor at the AZ Tucson. What do you think?
Yeah, no, thank you, Professor Takwin, for such a fascinating talk. You know, I think the idea of laminar flow and its contribution to atherosclerosis has obviously been around for a while, and clearly disruption of flow contributes to the development of atheroma. You know, I think one of the important things to understand why it does that is because the endothelium is a live structure, and the induction of zones of turbulent flow and low shear stress actually causes a molecular upregulation of cellular adhesion molecules like VCAM1, ICAM1, etc. So I think you are absolutely correct. You know, I think the main problem that has dogged us is that certain things we can't fix. Like, you are born with a circumflex that comes off at 120 degrees. You know, how do we ever change that to make it not come off at 120 degrees, you know, if you were born that way? And then also people with very tortuous vessels, those people must have a lot of turbulent flow, but oftentimes they don't have much atherosclerosis. So it's a very complicated question. And it would be amazing if we could actually visualize the turbulence besides with contrast injection. I think the problem with sub-opacification contrast is that, you know, you can change how it looks by simply increasing your injection rates. And I think CT, FFR, and QFR, etc., in their complex molecular modeling of turbulence, you know, under those conditions, you know, I know Habib Samadi has done a lot of very nice work, like your work as well, demonstrating all of these things. And, you know, one of the theories as to why the BVS fail is because of the ultra large 160 micron struts, and the pattern cause a lot of turbulence over that surface. So yeah, I think you are headed up the right way. I think the main question is how do we make turbulence less?
So I have only one answer, and so because we have to go to the next talk, you see. You mentioned about the author who did that, who did the study. Is he from Singapore, right?
Habib Samadi? No,
Yeah.
he was associate editor of Jack. He was one of my attendings at Emory. He's done a lot of flow with the Georgia work with the Georgia technology.
Georgia Tech, yeah. So now let me answer about Professor Kwan. It's very clear. So now we have usually we have a lesion at the right coronary artery. It is about it's a 0.24 second after the flow go in, because this is the transition between the diastole and systole. If the diastole, the flow go in, and systole blood go out, and they collide and cause a lesion there. So when you put a stent, what happened? Surprisingly, and we can show very clear, the flow go directly very fast, because you make the lumen bigger and stronger. So the flow very, very fast. This is the beneficial mechanism of stenting. It's very clear. It is universal. I saw all the time. We have all the data like that. You see, in the past, we couldn't have it because we have the bare metal stent. So the in-stent stenosis is the first 3 to 6 months. But with the DES, we don't have the endothelial of formation early stage. Now we have the long term, and the flow go fast, go past that area and cause no lesion. And when it go distally, the artery becomes smaller. Artery is going smaller, then they have laminar flow. By the Reynolds formula, the diameter, the bigger the diameter, the more flow. So a few weeks, last week I have a patient with and a really small change in the coronary arteries, the flow is very turbulent. So it's very clear. I can send any doctor one. I can send the film about that. This is we have to. This is we know that stenting helps the patient, but clearly we see that now and we see the mechanism. Thank you very much. Okay.
Thank you. Professor Thạch Nguyễn. Very interesting and presentation. I have the one question for the patient. We know that with the very low shear stress in your study, the patient will have the apoptosis of the endothelium of the coronary artery, and the LDL cholesterol easy to go into the inside the endothelium coronary artery and cause stenosis. And for in the future, what do you think for the patient with the acute angle of
hello, Wuhan. You talk about the patient with acute angle, right?
Maybe Dr. lost connection.
Yeah.
So I think Professor Thạch Nguyễn can answer.
Very simple. You remember when you did many times we did the angioplasty with stenting, we changed the curve of the arteries, and we keep asking ourselves, did I do a good job? Did I do correctly? In fact, my patient many times we changed the curve, and the patient did very well. So I say we're okay with that. We should change, no problem.
Okay, so I think it's the time we move to the last presentation. I would like to invite Dr. Nguyễn Đỗ Anh with your presentation.
Can you see my screen?
Yeah, we can see.
Okay. Thank you for your kind of introduction. This morning we have to change to what the very difficult case of complex left amplification, the lesion. So my presentation is the last presentation. It's not really some difficult case like this. So it's not really the dilemma, but it is a situation met in daily clinical practice. How to deal with the side brain ablatement, the verification instantly. We have two things to concern with this situation. The first thing in this situation, we have to perform the target coronary revascularization as soon as possible with the very special side brain to affect the large territory of myocardium. The second thing is that can our surgery conform to the current EPC consensus to almost all the left amplification deletion, in which stepwise professional stenting is the standard approach. So now we can we start with the first option, the first situation when the side brain is not the cubic lesion. We start with the first case, the lady, 61 years old with the acute anterior mine. So in the CAG show that RCA is dominant and normal. We see that significant stenosis from body to distal left main extend to proximal LAT and totally occluded. So I just wait. So it is extend so that is the cubic lesion. So it's the quite large and just borderline stenosis, just around 30 to 50%, and very short length lesion from ostium to proximal sub. Also, is nearly perpendicular to LAD. So this is the complex or the non-complex lesion. And what is our approach to stepwise professional stenting versus the upfront two stent? So this is the left main perforation does not to meet the with the criteria to complex lesion. It's just got only to two minor criteria, and so it's a favor to provisional standing with the with the focal disease insert is the wide angle between the LD and SERT, and also its significant stenosis is osteum L SERT. So we redirect the left main LAD and sending 2DS from the left main to LAD. But after the left main LAD stenting, the patient feels severe chest pain, TB dropped. She showed that the side brain is compromised. So what we do next? We dilate and final kissing kissing balloon inflation, and I will assess will help us to make decision next, or directly to viral stenting to TAP or Kulos technique. So we try to so we distance rewire to SERT and delay with the NC balloon, but the flow is still not good and hemodynamic unstable. Because the same side with the LD and so we decided to directly the bioculus technique, bioculus standing. With the standard 3.5 deployed in left main RLC and the first spot 10. The next we rewind the distal rewind to L6 again, and also high pressure post dilatation at preference of fully expansion stent before performing final kissing balloon and report with the follow balloon, and that is the final results with the TMD flow 3, the restoration with fully stent expansion. Now we move to the second case. The lady is 49 years old with extensive anterior MI. So in the so she showed that the normal and the dominant RCA. This looks the significant stenosis from distal left main extend to proximal LAD with harshness, slow flow. There is a cubic lesion. So it looks quite smaller, and the LAD is quite normal and nearly the perpendicular to LAD. We noticed that they also had the height, the OM1 and OM2, slightly larger than the smaller, the diagonal 1 and 2 in the LAD. And again, it's also based on the definition study criteria, is also the non-complex lesion, which just only the 2 minor criteria. And it's also favor to the provisional approach with no the concomitant disease insert and no the stenosis as osteum SERT with the wide angle to LAD